Good morning, everyone. It is my pleasure to welcome you all to day 4 of this enlightening web series. Over the past 2 decades, we have seen various aspects of oral wound healing. So today we have Dr. Anurag Satpathy as chairperson of this current session on periodontal wound healing and regeneration. We welcome you, sir. Sir is professor in Department of Periodontics at Shiksha Anusudhan University, Bhubaneswar. We welcome you, sir. Now we will continue with this session and our train of education and with our esteemed guest speaker, Dr. HANNU LARJAVA. Over to you, sir. Thank you. Sir, kindly unmute yourself.
Can you see me and can you hear me?
You're audible and we can see you.
Excellent. So thank you for the nice introduction. And it's nice to have everybody back. So this is the second last day of the course. So we have covered so far basics of wound healing from clotting, inflammation to granulation tissue formation. We have covered extraction, socket healing, and gingival grafts. And now we are moving to next to the tooth. That will be periodontal healing around teeth and can we regenerate the periodontal structures? So can we go from the left image to the right image? And answer will be that to some degree and not completely. So let's get started. So this lecture will cover periodontal wound healing, repair, regeneration, and the biological principles of nowadays treatment modalities that we use. So regeneration is a wound healing process, obviously. So it's part of this, what we have already learned, goes through similar phases, but has also some differences. So what do we know about periodontal wound healing? So the biggest difference between healing in the cut mucosa and next to the tooth is that we are healing tissues that we have soft tissue on one side, and then we have hard tissue on the other side, and that hard tissue also has a ligament. So that complicates things quite significantly. So we are now familiar how the mucosal wound heals, but it's a little trickier when we look at the periodontal wound, when we have different structures, so soft tissue, ligament, and the hard tissue, actually two kinds of hard tissues. We have the bone and cementum, sometimes even enamel is involved in the healing process. So what we need to do in the healing, try to restore all of those. So we have to restore the ligament, the gingival tissue, the epithelial attachment, and restoring the ligament requires both bone formation and cement formation. So it's a fairly complex process, and that's why we have been challenged over the decades and decades. How are we able to do that? With some progress, obviously. So regardless where the wound is, like we have already learned over the last 3 days, that all healing process will go through the same kind of steps and phases, starting from the hemostasis and inflammation, epithelium then migrates, granulation tissue forms, and then in the case if we are successful with next to the tooth, the ligament needs to form, and then ligament formation requires the formation of cementum and alveolar bone. So it will follow the similar kind of tensile changes that in the soft tissue. but a little bit different because now we have the tooth on the other side. So the tensile strength takes about 2 weeks to reach about half of the normal tissue for rupturing forces. So other than that, we have the new epithelial attachment, we have the granulation tissue, and if we need to have a ligament formation and the bone formation, that will take several weeks and months to get to the normal level. So what determines whether the wound healing and how the wound healing proceeds next to the teeth? So basically, if you make a wound next to the tooth, you remove the tissue between the tooth and the soft tissue, there's a race. So all those cells and tissues want to go into that space, to that void that was now created. So there's gingival epithelium and the connective tissue, there's PDL and alveolar bone that are racing into it. And who wins dictates how the healing will proceed. So you can have different options of the healing depending who wins. So typically in most of our clinical procedures, the long junctional epithelium, meaning the epithelial cells, win because they are the fastest. We have already discussed that. 0.5 millimeter per day. So they are typically the fastest. And if you don't do anything else, we just do a flap surgery, for example, it would always result in the formation of long junctional epithelium. In some cases, we can create collagen adhesion. That many times happens if you cut the tissue and then you reposition without removing the fibers from the other side. So it would be similar to the mucosal healing. Usually you will have resorption, you will have new cementum formation, ankylosis, and regeneration. So we will cover a little bit of all of that. So what happens in our everyday procedures, scaling and root planing that we do for the periodontics patient, the periodontal patients? So epithelium is that wins. If you do open flap surgery, even with the bone grafting, if you don't do anything else, most of the time epithelium migrates exactly where we touch the root surface. So if you have a 7 millimeter pocket and you scale the root surface, that's where the epithelium will migrate, and you can calculate 0.5 millimeter per day. So it takes 2 weeks and epithelium has all gone to the level where you touch the tooth. So it always wins because it's the fastest, and then everything else heals around it. So obviously, when you do periodontal surgery, 2 things happened. You know, there's some shrinkage of the tissue, and then there's attachment to long junctional epithelium. So, and it's a relatively good way of healing. So studies over the years have shown that the junctional epithelium can resist biofilm almost equally well as the regular junctional epithelium. So the long junctional epithelium is functionally, it's not the regeneration bit, but it's providing us healthy solutions for our surgical procedures. So collagen adhesion doesn't really happen in our regular surgery. Maybe at the very bottom, if you have a really deep lesion, you may have some parallel collagen formation. If you here in this tissue, if you just open the tissue for access and you don't remove the cut collagen fibers from the root surface, they will refuse. So, but typically we don't get a lot of collagen adhesion during our surgeries, to some level, but not very much. Resorption of the cementum is not uncommon anyways, but sometimes the gingival connective tissue can invade the tooth surface, and And it can become a pathological process when we talk about external resorption. So actually the cells become almost like plastic cells that can remove the hard tissue. So small amount of resorption is probably a normal process, but if it continues too far, then it's a pathological process. And those all studies from Karing and others were showing that, some cases gingival tissue can do this thing, at least in experimental conditions. New cementum formation requires, it's usually a cellular cementum that forms if we are lucky, and we are using some special techniques. Typically, with our normal procedures, if we don't anything extra, we don't really get any cement formation. That's why we don't really get any new attachment or new periodontal ligament, because we don't have cement formation. So you have to have do something extra to get cementum forming. You may get bone formation. That has been shown in many studies, but the bone forms higher where it was before. But then there's a long junctional epithelium between the bone and the root surface. So that's not true ligament adhesion. So it may look good in the radiograph, but you may have long junctional epithelium between the bone and the root. Sometimes you can get ankylosis if there's a replacing resorption, so the tissue will resorb and the bone will start growing. But you have to keep in mind that the bone is the slowest of all these tissues. So to get ankylosis, it's relatively rare phenomenon in general. So we don't really have a lot of that. So mostly it is going to be long junctional epithelium unless we do something extra. So we need all these 4 things for periodontal regeneration. So we have to have a functional epithelial seal that can be long junctional epithelium or a normal junctional epithelium in length, but not like 5 to 10 millimeters. We have connective tissue fibers that actually attach to the root surface, and that requires new cementum formation. And then if you want to have a ligament, then we have to have alveolar bone restoration as well. And many times these cannot be, you cannot tell without histology whether any of these things happen, because radiographs will only tell us what happens in the hard tissues. So because of the race, there has to be some sort of, we need to be able. Please mute yourself. So we have a race. So because epithelial cells always win unless we do something else. So we have to do something else, and we have to exclude the other cell types so that the epithelium cannot get into the root surface. Otherwise, it will migrate along the root, and there will be no cementum formation, no ligament formation, because the epithelium wins. You also need to be able to stabilize the wound environment so that it will be appropriate for the right cells to migrate into that spot. Most of the regeneration, we think it's caused by some sort of stem cells that are, or pre-differentiating progenitor cells that migrate into the site. Some of them probably come from periodontal ligament, some of them come from blood, and then those are the ones that then are able to make us cementum and the ligament and the bone. So there are a few ways that the clinicians have then approached this, excluding the wrong cell types and trying to attract the right cell types to do the right things. And initially, the first modality was guided tissue regeneration with or without scaffolding materials. And then lately, other biological factors have been added to trying to do the same thing. Stem cells are not truly yet in clinical use, so I'm not going to talk about. They have been used experimentally, but not really in a normal clinical practice. And I'm not going to talk much about bone morphogenic proteins because they haven't been really established as a good biological way of regenerating periodontal ligament and cementum. So we are trying to stabilize the blood clot and prevent the epithelial migration and to some degree the gingival migration into the site where we want the cementum to form, a ligament to form, and the bone to form. So how do we do that? So the guided tissue regeneration was designed to guide the ligament and bone formation, so we can get cementum, bone, and the ligament forming, because the barrier membrane will exclude the soft tissue, including the epithelium and connective tissue, from coming in contact or migrating into the site where the regeneration is supposed to happen. So objectives are getting good blood clot and stabilizing the clot, preventing epithelial downgrowth and excluding the gingival connective tissue, and providing space and time for cementum and ligament and bone to form. So this is from our wound healing book. Vivek has done a lot of studies on regeneration with membranes, and he had done a lot of collagen dog studies with the critical size defects, and he has shown, like in this slide that you can read on your own time. I will just explain that, if the space is not provided, so here's the membrane providing space, and I mean, in the dogs you can put the membrane over the teeth and pull the gingiva over, so you can actually do these things. So in humans, this is not possible. But he has shown that if the membrane will collapse against the root surface, you will not have any bone formation. So basically, you have to provide the space and stabilize the clot. That was kind of the message from this study, that if the clot is stabilized on the root surface and space is provided, the bone and ligament will form against exposed and previously diseased root surface. So, I mean, these studies were done since 1980s to show that the guided tissue regeneration can actually do some of these things to some degree. And there's a lot of clinical and animal experiments showing that this approach is a viable option to regenerate the tissues around the teeth. And it was used and still used by some clinicians on intrabony defects and class 2 furcation defects, especially in the lower molars. So the idea is that when you have your defect, you will have your membrane. You don't actually, I mean, initially we didn't put any bone grafts underneath to support the membrane. That's just the barrier membrane, and then you suture the tissue over, and that will give the space for the ligament and the bone and the cementum to form and actually form the periodontal ligament and bone and everything else that we need. So initially, Teflon membranes, PTFE E-membranes were used, and we probably, the older periodontists, have all used them. Cortex membranes, they are not really in use anymore. Most of the clinicians, if they still use membranes, they use collagen membranes, and there are many different kinds. They are cross-linked or non-cross-linked. So cross-linked means that they will last a little longer. And there's no clear evidence that one membrane will be better than others. So why we left the Teflon, why don't you use the Teflon membrane anymore? So the main reason is that they easily get exposed and they collapse. Like they're no longer in use, and I don't think you can even buy them, at least in Canada. So if you have a kind of a nice typical infrabony defect, you can put the membrane and cover it, but you already see that there's some collapse of the membrane because you don't have any bone graft underneath supporting it. So it was used with the bone graft as well, but in this demo case, it wasn't used with the bone graft just alone, because you don't basically, for the biological principle, you don't need the scaffold underneath. It was suture and it got exposed. And then it can get infected too, and the membrane needs to be removed. But re-entry was done, and you can see where the membrane kind of collapsed. The bone did form and fill the defect quite nicely, actually. But because of all those issues that were involved in using Teflon membranes, furthermore, they were not easy always to adapt to the root surface, because if there's a kind of an opening of several millimeters, then the epithelium will grow on the root surface, and that will kind of defeat the purpose of the regeneration if the membranes are not adapted to the teeth really, really well. So I think some folks are still using collagen membranes, using the same techniques, and that's fine. There's evidence that they work equally well. And then other folks have moved to doing kind of a mini flaps, and they have different names. They can be minimally invasive techniques trying to regenerate ligaments. Sometimes they are used not so much with the membrane, but they are used with some biological materials, and we will discuss that. So there are many ways. The whole idea is that you open as little as you have to get access to the root surface that you need to clean, and then you close it up. And the mini flap, there's not really a lot of evidence that if you do mini flaps, that will lead to a more survival of the teeth, but it may work equally well than your regular flaps, and in some cases may be better, especially in the aesthetic areas. So, as I explained with the membranes, the grafting materials were used, mainly the bone grafting materials, for tenting the membrane, so the membrane doesn't collapse into the defect. But they can be used alone. But as I said many times, that doesn't, if you just use the scaffolding bone grafts, they don't lead to a biological regeneration, because epithelium can still polymigrate on the root surface quite deep. They're never so hermetically attached. So it may offer some support for the bone formation anyways, maybe less degree on cementum, unless the bone graft will block the epithelial migration on the root surface. So there are different allograft and xenograft that we already discussed previously for extraction socket healing. So here's a little table that I wrote some years ago for the book, that were the materials that were available at that time. And things haven't actually really changed that much, although some more materials, the biological agents, have been in clinical use. So the clinicians started moving from the membranes and thinking about maybe we can add some biologicals to do the same thing as the membranes were doing, providing the space, stabilization of the clot, and preventing the epithelial cell migration. So various products have been developed over the years and tested with some success for a number of them, and I have mentioned a couple of here. So in Canada, we mainly use the enamel matrix proteins as ENDO from Stroman, and the PDGF, which is same as GEM21 from OsteoHealth, that comes with its own kind of a bone grafting scaffold materials, beta-3 calcium phosphate. So all these materials that I am listing here, and P15 is a collagen adhesion peptide that we don't really typically use in Canada that much. I don't know exactly why, but it's please mute yourself. So it never became really popular, and I don't know which ones are available or even approved for clinical use in India. So I don't know. But anyways, as you can see from the potential mechanisms of these growth factors and differentiation factors and matrix enamel matrix proteins, the potential action is very similar. So recruitment of stem cells, pericytes, proliferation of fibroblasts, almost all of them is the same kind of action. So they probably are all somehow involved in the recruitment of stem cells or progenitor cells into the wound site. And some of them, like enamel matrix proteins, and we have shown that, and others that, for example, it can block the epithelial cell attachment. So some of them work in that way, some of them work with recruiting cells that are promoting the healing into those sites. So as I said, this is in use in Canada for periodontal regeneration that was developed some years ago. The tricky thing is that in clinical studies, they tested two different doses of the PDGF, the 0.3 milligrams and 0.6, and it was only effective at the concentration of 0.3 milligrams per milliliter. And it's provided in this white material, which is the beta-3 calcium phosphate carrier. So you mix it and you place it into the bony defect. So the animal and human studies show that promising results in regeneration, stimulates fibroblast osteoblast proliferation, and increases the recruitment of pericytes and stem cells, and recommended as GTR for class 2 furcations and intrabony defects. So if you think about it, it's a concentration dependent, so you have to mix it exactly what the manufacturers recommend. So you can't mix it poorly and you have higher concentrations in some areas and lower concentration in other areas because the product may not work as well. So there was a recent article about the GEM21 or the PDGF. So 25 years ago, I think it was the first human studies. And the conclusion from this review was that it has been extensively applied for periodontal regenerative procedures and for the treatment of gingival recession, showing consistent and positive outcomes. So it's not a miracle treatment, but it has some positive results in many clinical trials over the last 25 years. So we have some some evidence that it works. Whether it's a miracle treatment, I don't think so. But it has shown to be somewhat effective. The Pepgen P15, it's a collagen adhesion peptide that can be applied with an inorganic xenograft or in the hyaluronic acid carrier in a hydrogel. As I said, in Canada, we haven't really used that very much. It has had some positive results in clinical trials. It's still available, but I don't have a lot of personal experience using it. Then moving to the enamel matrix protein. So, and especially when we talk about Emdogain, and I don't know if Emdogain is available in India, but nevertheless, it has been used for over the last 25, 30 years for periodontal regeneration. And it's an enamel extract, basically, that has mainly amelogenins, because enamel that is not mineralized contains mainly like 90% of all proteins that are amelogenins. But there are other proteins that have been listed in the slides present as well, and we don't know really how they contribute to the outcome when we apply the enamel matrix proteins in the periodontal defects. So how Emdogain or enamel matrix proteins might function in the ligament. So they may do, as I already mentioned, promoting the recruitment of mesenchymal cells. They may promote an attachment of cells to the root surface, but the epithelial cells don't really like it. So we have done studies; they don't basically attach on Emdogain, so that serves as a deterrent for the long junctional epithelium formation. And then there's some evidence that there will be some cementum formation and osteogenesis when you apply enamel matrix proteins into these defects. So it's provided in the propylene glycoalginate carrier in a gel that is mildly antimicrobial to bacterial growth. So it's very hydrophobic. So enamel matrix proteins, many of them are very hydrophobic, so they precipitate on the root surface. So clinically, what you need always do that you have to apply that to the scaled root surface, even if you use scaffolding bone grafts. Otherwise, it will never really do the trick that you are hoping that to do. So it will increase fibroblasts. Fibroblasts like Emdogain, epithelial cells don't. And stem cells probably like Emdogain as well. So it's also related product has been approved for treating chronic ulcers. So whether chronic periodontal lesion resembles chronic leg ulcer, I'm not sure, but it's applied. It's actually approved to be used for both cases. So what the old clinical studies were showing that when you have periodontal defects that are 6 millimeters or more, and you have 3-wall defects, you may that is 4 millimeters, then you should be able to get some bone fill, and some early studies were showing that should be about 60%. But there's a high variation of these studies, and it may be very much of the clinician-dependent procedure. I have some colleagues who don't use Emdogain or enamel matrix proteins at all because they say that it doesn't work in my hands. So there may be something special how you actually are applying this, and the studies are equally sometimes heterogeneous, showing the efficacy of Emdogain in the studies. So I may elaborate that a little bit on that. So I already mentioned the mini flaps that have been used for trying to achieve a regeneration of the periodontal tissues, and many times they are done with the endocrine or element matrix protein. So mini opening, you have to get it on the root surface. You don't have to apply a bone graft, and then you just close it up and wait for the healing. So it's not different if you do a fully open exposure. It's just that it's very conservative, and it's trying to preserve the papillae and give better aesthetic outcomes. So there are many kind of systematic reviews about medium and long-term clinical benefits of these treatments. And there's one that was published relatively recently in Journal of Clinical Periodontology. And their principal findings were that the periodontal regenerative reconstructive therapy in intrabony defect results in better clinical probing depths and improvements in probing depths and attachment level comparing to the open flapped debridement alone in medium and long-term basis. The combination approaches based on this review, that means GTR plus grafting or endogain plus grafting appeared as more effective compared to the monotherapy. So this is what many of us are doing. Personally, I have left membrane use, so I don't do a lot of GTR, but I do a lot of endogain and grafting. So either way, there seem to be better results than doing the open flap debridement alone. So I'm going to show you a few cases from my own practice. So here's a 10-millimeter pocket on the mesial of tooth number 3-3. And you think that there could be some tree-wall defects, so the patient was told that we might use endogain in this case. So the flap is open, and you see that there's some vertical component, but it's not all vertical. There's some horizontal component as well. PREF gel is applied because that's part of the protocol. The PREF gel is EDTA that is used for conditioning of the root surface. So it's basically etching the root surface to some degree for 2 minutes. And then endogain is applied on the root surface. Flap is closed. And then additional endogain is applied when the flap has been closed. And then in this case, we got about 5 millimeters of gain of attachment, some increase in the recession, but the pocket depth is only 3 millimeters in this case. So pretty good results, some recession, but that we don't no longer have 10-millimeter pocket. It's instead of 3 plus 2 millimeters of recession. Here's another case, distal of the lower 6, and endogain can be used alone. But if you want to prevent the gingival tissue from collapsing into the defect, then the scaffold might be useful. And as in the previous study that I explained, that using a bone graft and endogain together might give you better results than open flap debridement alone. So that's what we nowadays almost always do. So you apply the endogain to the root surface first, then you mix the endogain with your bone grafting material, and then you apply that. It's like a little oatmeal. You apply that into the bony defect, and then you close it up. So there are several cases where we can show improvement in pocket depths. Here's a distal of the 7. You can see the bony vertical component has almost disappeared. I mean, it's not absolute regeneration, but certainly improvement comparing to the open flap debridement alone. Here is a case that is pretty advanced. So we have 13 millimeters on this canine. Part of that is a vertical defect. Part of that might be a little bit a horizontal defect as well. 1 year follow-up shows quite a bit of bone gain into this level. It's not 100%. And there's 4 millimeter pockets remaining with 3 millimeters of recession that equals to 6 millimeters of gain of attachment. Distal of the 7 again, so we have 10 millimeters. 8 months later, it's a 4 millimeter pocket and clearly increased bone formation. So all these radiographs don't tell us anything about the biology of the healing. So we're hoping that we have actually cementum formation, we have periodontal ligament and all those things, but you would have to take a block and do histology to demonstrate that that's actually the case. Here's a 10 millimeter pocket on the mesial of the 6, and then the 14-month follow-up, we have 3 millimeter pocket left and some recession. Another 3-7, isolated 10 millimeter pocket, and 8 months later, we have a 4 millimeter pocket remaining, and bone level looks almost completely normal. Lower mandibular teeth that are supporting partial denture. For distal has vertical intrabony defect. Emdogain and BIOS, which is a xenograft, was applied. And this is an 8-month follow-up with 3 millimeter pockets remaining and 2 millimeters of recession. So it's not perfect healing, but it's certainly better than we can do with if we just open it up and clean and close. We don't usually get this kind of a healing response. Here we had a little advanced 13 millimeter pocket on the mesial of the lower canine. And we tried to do minimal opening, but since the pocket is so deep, we have to do some vertical incisions, and it's a very large defect where it's mainly one wall and some areas with the 3-wall defect, because sometimes you can't really predict what these defects are. So let's see what happened. So it's closed up, and then a year later, we have significant improvement, at least on the bone level around this teeth, and the pocketing has reduced to about 4 millimeters. Older lady who has a furcation defect, some calculus into the furcation, class 2 defect, 9 millimeters with pus, Emdogain BIOS applied, and 3 millimeter pocket left at 6 months of follow-up. Very advanced case of the lower 6. So you can see the defect. Emdogain BIOS applied 4-month post-op, shows good bone healing. So we have some residual pocket, but it's not too deep. Some of the most recent ones, this is a 1-year follow-up of 2-1 distal. You can see that there's a narrow pocket nearing the apex of the 2-1. And this is 1 year later. Again, we can't tell exactly what the healing response is going to be, but clinically it looks functional and acceptable. Here's an interesting case. It's an anterior bridge that the patient wanted to keep, although the quality of the bridge is questionable. So we had an abutment tooth that had this vertical component, the periodontal defect, and we decided to do the Emdogain BIOS. And this is a 9-year follow-up. The tooth and the bridge is surprisingly still there, and the defect looks like it's almost completely still healed. The bone level appears pretty favorable for that one. Here is again one of the more recent cases that I have in a lower canine with very advanced pocketing, and 1 year follow-up with very little pocketing beyond normal limits. So very good results. So for the wound healing book, I made this little table of my own cases, and I will show you this part. So what I please mute your microphones. So what I do with my residents, I always recommend them that you have to record your own success, so you can tell your own patients how things work in your own hands. So keep a little logbook and mark how you follow up your cases, so you can tell your patients what you could average expectations will be in your hands, especially for therapies that are shown to show a lot of variation between clinicians. So it may work in your hands, it may not work, or it may not work 100%, but it still works. So you are able to tell the patients that, in my hands, if the defect is like that, your hygiene is good, we should be able to get to this level of healing. So I did cases with Emdogain alone and Emdogain with BioOS. The follow-up was about a year, plus minus couple months. The results were quite similar, so we got a good reduction of the pocket depths in average from about 9 or 8 to about 3-4 millimeters. So there was some increase in recession, but there was significant gain in the attachment for both cases. So I did enough cases for myself to stop, so I don't really document my cases this way anymore. I just take radiographs and collect them after at least a year follow-up, just for my own fun. But it will be good to do for therapies that are operator dependent. Like regeneration seems to be operator dependent. So it works in somebody's hands, and it may be just how we apply for example, the Emdogain on the root surface at a certain point, and so forth. So, so I will like to summarize my first lecture for the day. And I think the summary is that the healing is different at the tooth soft tissue interface. And it's a much bigger challenge because you have to be able to regenerate the soft tissues, the ligament and the bone, and the ligament is not restored if you don't also be able to regenerate cementum on the root surface. Otherwise, we're always going to get long junctional epithelium, which is actually it's kind of a good compromise. And most of the surgeries where we have more shallow pockets and we don't have, ideal sites for regeneration, so it will still give us good results. But as part of the treatment planning, I think all the periodontists should consider looking at the defects, trying to figure out whether they have sufficient number of walls, because we know that it works better the more the walls you have for the defects. So 3-wall defects, intrabony defects are the best. So if you have those kinds of defects, I think, at least in my hand, a regeneration approach is better than just opening it up and cleaning it and doing nothing else. And as some of the studies have shown, then the combination approach is that what I personally do at the moment, which is enamel matrix proteins plus xenograft and white xenograft, because it will resorb a little slower than allografts. So that's the rationale in my own hands, but I also say that there's quite a bit of variability between the clinicians, how they are able to get this technique working. So I think we still have, you know, a lot of research to do, trying to get and optimize the periodontal regeneration to a higher level. So I don't think we are even close there yet. So there's quite a bit of work to do, but we have some tools that we can use today that I have just summarized for you. So thank you very much, and I would like to entertain some questions.
I request Professor Anurag Satyapati to kindly summarize it and ask some questions.
Thank you, Dr. Sir. Thank you, Dr. HANNU LARJAVA. It has been a wonderful learning for last 3 days into the deeper understandings of wound healing. And thank you for your insights today on the periodontal regeneration, which we all periodontists are actually struggling with because of the complexity and the nature of the tissues that we are dealing. As you rightly said, that the mechanisms are yet to be understood in totality today. And although if we do nothing, the long junctional epithelium would form. And as far as we are concerned, we have tried a lot of work such as GTR membrane, using biologics with the scaffolds, and we have yet to reach that final success, but we are still having some amount of, as some of the journals now say, defect fill, rather than they have gone away with the word of regeneration, and now because there is a question there, so the radiographically they would say a defect fill or a defect area which has been so. But apart from this, there are the questions that we have today are I would like to know your opinion on one of the few things, like how about regeneration? Is it different in the immunocompromised patients? And your thoughts about the root biomodifications and its implications, whether it really helps in the regeneration.
Can you hear me okay?
Yes, yes.
I think I've lost my video again, like we have had
Yes.
these issues over the week. So regarding the immunocompromised patients, so if their healing is compromised anyways, I mean, I think we have done these procedures on some degree immunocompromised patients. So I think you can do these things, but then when I also forgot to mention that every time when we are doing these procedures, when we are using bone grafts, we are actually putting the patients on antibiotics for a couple of days. So that will assist even if you have an immunocompromised patients to some degree. But, you know, it's really depends, you know, what level of immuno defect the patient has, whether it will be advisable to do these procedures and what you can predict from them. Regarding the root surface conditioning, so there has been studies showing, there was a Anita Badestein from Sweden, a periodontist, did many years ago. This is more than probably over 34 years ago. Studies looking at the different times of EDTA conditioning, and I think no conditioning at all. Personally, I don't think the conditioning of the root makes that big of a difference. Although we were thinking that way when the citric acid was commonly used in etching the root surfaces, exposing the collagen fibers and so forth. So I don't think it's critical using the PREF gels or the EDTA, but because it is the part of the protocol, I'm still personally using it. So there's no good evidence that it will actually will do something. I think the critical thing is that if you are using enamel matrix proteins, that it will precipitate on the root surface. Whether conditioning will be more critical for the PDGF, I can't really tell.
Thank you, Professor HANNU. Also, now we have much into practice the use of autologous platelet concentrates in the form of PRF and various forms of PRF. So would you recommend, and what is your opinion about the success and the use of these biologics for periodontal regeneration?
I will be discussing like LPRFs and the likes a little bit more tomorrow when we talk about the strategies for the future. Although the future is already here with those products because we can actually make them. There's not much evidence that they alone will introduce periodontal regeneration. So the evidence that if you only use the blood product, including LPRF, for example, and just do an open flap, there may be some improvement in the soft tissue healing rate, but it's not gonna change the regeneration or the healing outcome. So you will still have the long junctional epithelium and poly doesn't get much different outcome from the regular open flap surgery. So studies are a little controversial regarding using LPRF, and there are some applications, and I may mention them, where they have been shown to have some degree of success for using oral applications, but periodontal defects is not one of those. So as we are applying them now, there's no good and strong evidence that using LPRF, for example, would introduce regeneration. The healing outcome will be, maybe it heals a little faster, but the healing outcome will be the same.
Thank you. Thank you, sir. And thank you for sharing so many of your clinical cases with the use of Emdogain and BIOS, which is a huge learning for us. I would like to ask you, since we are not allowed a surgical re-entry nowadays because of the ethical issues, which was one of the methods to confirm the regeneration, whether it has happened or not, or bone formation. When we are using a scaffold like BIOS or any other bone graft material, how long does it really take for the alveolar bone to form back and replace the scaffolds that we are using in your experience so far, sir?
Regarding the xenografts like BIOS, I think we know from more from the studies that they have been used for socket preservation and sinus lifts and things like that. We know that they may last for years. So there will be some partial bone growth around the particles, but some particles may persist for a very, very long time. So that's why I was recommending that if you do socket preservation and you're actually placing an implant, maybe an allograft will be a better choice because it will be replaced it resorbs much faster. Xenografts don't usually, at least BIOS doesn't resorb that quickly. So it may stay there for years, and I don't know if it stays there forever to some degree, and then the bones forms around it. So it will be kind of a mixed product in the end.
Thank you so much.
Yes. One more note that, many times if you look at even my results a year later or so, you can still see some particles in there. So it doesn't look like it's all perfect looking bone yet. So I don't know how long it's going to take, but you know, the clinical outcome is what matters the most. So
Thank you so much, sir. And I would like to take this opportunity to thank Dr. Saif and GIAN and the Aligarh Muslim University for providing me this opportunity. Thank you. Over to you,
Thank you.
Dr. Saif.
Thank you. Now we move to next session.
Saif, I have an issue with my
Okay.
camera again. I may have to reset.
Yes. We can take 1 minute. After
Let's
1
take
minute, you
1
can
minute.
join.
And I
break.
will reset.
Yeah. Sure.
Thank you.
Welcome back. Moving on to our next session, which is on healing and maintenance around dental. Healing and maintenance around dental implants. The chairperson for current session is Dr. Farhan Durrani, sir. He is head of Department of Periodontology at Faculty of Dental Sciences, BHU. Sir has done immense work on implantology and has various fellowships to his name. To name one, he is currently enrolled in Digital Implant Dentistry Fellowship, New York. We welcome you, sir. Without wasting any much more time, we'll continue with our next session. Over to you, LARJAVA, sir.
Thank you for the introduction. So now we are moving to the last session in my lecture series that deals with healing around dental implants and what problems we have about dental implants and how we can maintain them. So it's all about the healing and maintenance. And I will start with this picture with the implant that has some clear bone loss, and if you take the implant out, you will see what's growing on it. So implants can have problems, and we will discuss that about it. So some years ago, editors in various journals were discussing the dark side of the implant treatment, and that was the peri-implant diseases and should we save more teeth? So the field went from removing all compromised teeth and replacing them by implant, especially with the younger generation of dentists. So they felt that every tooth that is kind of a compromise needs to come out, and implant will go in. And then now we are dealing with the massive amount of problems around the implants because the reasons that I will explain in the minute. So I'm an old periodontist, so we have done all these treatments in the past. We are trying to make the teeth better. We regenerate that. We were discussing in the last lecture, rather than taking the teeth out, we do root amputations, so we can even save half of the tooth and so forth, and we can maintain them successfully for good 10, 15, 20 years by doing periodontal treatment. So sometimes it's a better option to save the tooth rather than always pull the tooth out and place an implant. That has become a trend, especially with the younger generation of dentists. And I get referrals like this. Actually, this patient has been referred twice. In 1989, first time with the class 3 furcation defect, and then again 2015. Luckily, we had some radiographs spanning all this time. And this furcation defect has been treated with the regular maintenance any 3 to 6 months over the last 26 years. And in fact, it has shown relatively little progression over those years. So it will likely to survive another 20 years, and that may be enough that is needed. While someone who only see one radiograph thinks that, okay, let's take this trouble tooth out and put an implant there. So with implant dentistry, we have a lot of problems that can stem for various issues, and we will discuss those during this lecture. And part of that is the healing, and part of it's probably poor planning and number of other things that we will be discussing. I think we should start about the healing outcome around the soft tissues around the implant. We don't have to discuss the osseointegration is a well-established fact that the bone will fuse to titanium implants. So we don't have to discuss that too much. Some implants may have faster osseointegration than others, but nevertheless, they are all now rough surface implants that speeds up the bone formation and osseointegration around implant. The soft tissue is a little bit of a problem because the attachment is not, it's similar, but it's not the same. So, paper 2011, we were already discussing this, like it looks more of like a scar around the implant comparing to the having functional junctional epithelium and the supracrestal connective tissue around the teeth. So, for example, studies have shown that when we have the junctional epithelial marker of laminin 5, although the epithelium seems to be attaching to the implants or abutments, the level of the amount or the length of the laminin 5 adhesion is relatively limited. So epithelial adhesion may be longer, but it's not as functional. Collagen fibers are parallel, and they don't run into the neck of the implant or the abutment that may be there. And we have to remember that most of the implants are placed at the bone level, so all the adhesion to soft tissue you can have is into the abutment that can sometimes be removed various times. So it's an ever healing situation. So we will discuss that a little bit. So also vascularity is more limited around implants and abutments than it is around the teeth. So the soft tissue adhesion makes these implants a little bit more susceptible for disease. And then I was discussing in my couple of previous presentations about experiments from the group that has been in China, who have been doing these experiments, what tissue or how the junctional epithelial cells contribute to the peri-implant epithelium. And if you cut the junctional epithelium away, if you look at those stem cells that make the junctional epithelium, you have much more limited number of them in the peri-implant epithelium. So it's not functionally the same, and it doesn't have the same kind of stem cells that our normal junctional epithelium has. So it has a very limited, if you compare the peri-implant epithelium here, it has very little green comparing to the epithelium that is next to the natural teeth. So there's a difference in where the cells came from that will be next to and attached to the implant surface. So there are phenotypically different. One of my graduate students was also looking this. We made replicas of the surface of the peri-attachment epithelium, because these were all bone level implants. So you can see how nicely the oral epithelium kind of migrates down. And you can imagine that there's a very little attachment here when this abutment is moved back and forth. So that creates the pocket and very little attachment, because you would have to have kind of a ripping off the epithelial attachment if there would be one, and that should look more of red like here. So in the end of the day, we have a long epithelium leaning on the implant abutment, and then very little attachment, and then some inflammation, and then the bone level implant. This is the most typical way if you have a bone level implant, as most of them are. There are Straumann tissue levels and others, but most are designed like this. And especially if the abutment, if you move all the time, this epithelium polyp migrates all the way down, and basically you don't have much of an attachment at all. So that makes these implants in general more susceptible for having deep pockets and having problems in the future. So implant success requires a number of things. So implant can survive, but they may not be successful. So they may be in the wrong locations. They may not be functional and all the rest of it. So the terms needs to be the right ones when we are discussing implant success. The selection of patients is implant. Has the patient actually earned to have an implant in their mouth? Are they committed to aftercare when they get implanted? So We know from the studies that the most critical part probably in the implant success is to select the patients who get the implants. So obviously there are medical and dental factors that may increase the risk of complications, and other factors that we will discuss today. And then you have to have appropriate diagnostic data, select the right kind of an implant, and place them in the right place, and use components that are from reputable implant providers. So I will touch a few of these risk factors for implants before we talk about the maintenance. Not so much of the... Please mute your microphones. And some of the other functions I will leave from this presentation. So few words about general health and implants first. So there's a number of papers that have discussed the systemic conditions that may have reduced survival rate of implants. And we have already discussed during this course about the diabetes, which is one. And then bisphosphonates may increase the or reduce the survival of the implant, radiotherapy, and smoking. Diabetes was covered, so if the patients are the control of diabetes is in good shape, then the failure rates are no different from non-diabetic patients, but there may be lots of patients who have diabetes who are not aware of it, or whose control of diabetes is not at the high level. So those patients are in risk having complications from implant surgery, and they may have more failing implants if their diabetes is not well controlled. This systematic review was saying that, importantly, all patients with history of bisphosphonates are at risk of osteonecrosis of the jaw. So they have to have an informed consent obtained before any implant placement. So they have to be aware the risk is not very high, but nevertheless it's there. Smoking. So that comes up in many of the reviews regarding implants and complications. So they may have complications from the implant surgery itself, but they may have lower success rate over time. And I will show you some graphs about it. So it's not an absolute contraindication, but again, the patient needs to be informed that there's a higher risk of things going wrong if they continue smoking. And especially if they have other things, like if they have diabetes that is not under good control, if they have bad oral hygiene, so then they may not be very good implant patients in the end. This is from an old study from Levine and ourselves a couple of years back, 10 years or more, looking at the failures on crestal bone loss on smokers and non-smokers, and the failure rates actually start dropping after about 7 years.
मीटिंग वाला लिंक नहीं आया ना अभी मीटिंग का.
Please mute your microphones. So you may have initially a little bit more failures in smokers from the implant surgery, but then the levels are about the same, and then you get more failures after about 7 years. So and if the implant survival rates drop below 80, that is very, very low, because normally we are in the 90 to 95 percentile region. So this is a very low cumulative survival rate. So with Dr. French, we did an analysis of his patients, and they are a very well maintained patient group. But again, if you were a heavy smoker, in this case, we only had heavy smokers and no non-smokers, you will see that about a year after there's increase in crestal bone level, and also it's not so much in his group. The patients don't get a lot of bone loss after implant placement, but after about 7-8 years, you will see a big difference in terms of how much bone has been lost at the crestal level in smokers comparing to non-smokers. So it is a risk factor. Here's just one example of a young patient who had missing lateral incisors, and they were replaced by the implants, and the smoker, and both implants are now not doing really well. Continuously, the oral hygiene level comes up in many of the studies as it relates to periodontal disease, but it also is a risk factor for peri-implantitis. And peri-implant mucositis that is caused by the black biofilm is highly prevalent, like almost half of the implant, at least third of the implant have peri-implant mucositis, and if that is not treated, it can then lead to peri-implantitis in some years later. So it can be reversed. It's like gingivitis on natural teeth. So oral hygiene is very important. So some patients do not get implants if their hygiene level is not high. So what we do here in Canada, in the university clinics and in our own practice, that every patient who comes to the office get full perio exam, regardless of whether they get one implant or a number of implants. So we want to know what the condition is around every other teeth, and we want to know if they have periodontal disease, and if they have, how severe, and that needs to be treated before we start placing implants, and so forth. So we see a lot of patients coming to the specialty office now from the GP's office, where implants has been placed here and there and everywhere, with patients with poor hygiene, with no proper planning, and then around failing dentition. So if you have failing dentitions and then you put implants here and there and everywhere, it's a disaster to treat in the end of the day. That was the Levine study. Let's move on. So let's talk about the implant maintenance programs. So obviously, when the patients have received implants and they come to our office, I think they need a little bit special care and special examination. So obviously, we do all the things that we do for our regular patients, but we do look carefully about the implants, the colors around the implants of the gingiva, the amount of keratinized tissue, is the implant crown mobile, or the fixture, or both, is the bleeding, how profuse is the bleeding, and especially pus formation. If you squeeze around the implant, and we always do, if there's pus coming, that's a bad sign. So there's a lot of research done on the coloration of the pus and peri-implantitis, and there's clear correlation. So we many times, especially if we see some bone loss, we will do a squeeze test. You squeeze, or the pus can come when you are just probing the patients. Obviously, we take radiographs to look at the bone level, look at the occlusion, periodontal status, document and communicate, and so on. So peri-implant conditions have been classified by many organizations, and they go from the health to then having the peri-implant mucositis, where you have inflammation around the implant, but no progressive bone loss, and typically no bone loss beyond 2 millimeters. While in peri-implantitis, you have then bone loss around the implants, in addition to having bleeding or probing and sometimes pus coming from the suppuration coming from the side. So if they also distinguish whether it's your patient or somebody else's patient that you haven't seen before, so then they put the bone level threshold a little higher. And then we will discuss this a little bit. It can be then divided whether it's early, moderate, and advanced. And that may have some treatment consequences, like many times the advanced, there's a consideration where we're going to remove the implant or not, while we can probably treat the early to moderate diseases to some success. Implant probing, so there was a long time kind of an emphasis from some prosthodontists and others that the implants should not be probed, and if they should be probed, it will be probed with the plastic instruments and so on, and that's kind of all nonsense. They can be, I mean, typically you are not probing the implant fixtures that are on the bone levels. You are probing the abutment. Hopefully, if you are probing the implant and scratching it by probing, then it's kind of too late already. So, but the probing needs to be done with the very light force. Otherwise, you are probing the bone level. So that has been shown in the studies that should be much or less, I would say 15 to 20 Newton centimeters than anything else. So very light probing, unless, and because of the healing of the tissues, I already explained the soft tissue healing. Otherwise, you will be probing bone level. Bleeding or probing, if it's more than half recall visits over 2 years, may have some prognostic value for peri-implantitis. But when you see pus formation, suppuration around the implants, you know that things are not going that well. So we always look at the pus. Pus is a good indicator that something is going wrong, and you don't really want to see that. Radiographs, we take radiographs typically at the time when the implant is placed, obviously at the time when the crown is placed on the implant, and then after 1 year, and then we do recalls after that, probably every 2 years, is everything stable. The only thing about the implant is that the beam angle needs to be less than 15 degrees, so we actually see them sharp, the threads of the implant sharp. Otherwise, they are not diagnostic. So if you have two implants that are in, the beam is in the right angulation on this implant, but you need to take another radiograph of this implant to see the sharp threads. Maintenance, whether it's a newly placed implant, perimucositis, peri-implantitis, what's the self-care and office care? So this is a typical bone level implant with the immediate healing abutment, and it stays there for about 3 months. Then we do also integration check, and then the crown can be placed. So we don't typically probe these. The patient can clean on the top, and if the patient goes to a hygiene appointment, it can be polished and airflow can be applied on the top, but it doesn't need much more anything than that. So if you have a healthy implant like we have here, gingival tissues are healthy, probing depths are up to 5 millimeters, depending how deep the implant has been placed. There's no or little bleeding on probing, no pus, no radiographic bone loss. You will do air polishing or hand instrumentation or ultrasonics. Calculus is very rare, so you probably don't need to do any calculus removal, and then you just do self-promotion. Remember that your instrumentation is around the abutment because the bone level implant is not, the threads are not exposed. So the patient can use interdental brushes, regular toothbrushes, electric brush, and many of them we recommend water pick for cleaning around. So those are the things that are typically recommended. Dental floss can be used as well, but probably not going too deep into the sulcus. But if the abutment and if there's a little discrepancy, so it's not smooth transition from the abutment to the crown, you may have some catching for the floss. So you have to be a little bit careful that you don't cause any floss threads to remain behind. So in terms of mucositis treatment, you can use air polishing with typically with glycine or erythritol particles that are small, and they can be used in the pockets 5 to 10 seconds per surface. It does not remove calculus. So we have in the office a machine like this. So the air flown with erythritol powder that we use these perio tips that then will be used to remove the biofilm in the sulcus. And they came first with the glycine. Now they are more recommended erythritol because it's a little bit more versatile. So it can be used for the hygienist can use them for stain removal, natural teeth, and around implants as well. Glycine is not as effective for the stain removal, so it's not as versatile. Otherwise, in biofilm removal, they are probably equally effective. We don't really use sodium bicarbonate in periodontal maintenance. So ultrasonics can be used. Typically, I recommend using them with the light lateral force without any extra tips, because these will leave plastic residue behind when you put them in the pocket and apply the force on the ultrasonics. So regular tips can be used with light force for the biofilm removal. And remember, you are not scratching the implant because the implant is supposed to be in the bone. So you are working around the abutment of the crown and with light force, lateral force. So peri-implantitis. So it's very common around implants. So up to half of the patients may have that, meaning that they have bleeding on probing, pocket tips up to 5 millimeters. They don't have pus coming around, so they will then receive the same kind of treatment as the healthy implants. So biofilm removal by air flow instruments or ultrasonics. Calculus is very rare on these implants, except those implants that the threads have been exposed and then are above crest. So peri-implantitis is not always well defined, and the diagnosis is not well defined, and I will explain a little bit why. But typically we diagnose that when we have deeper pockets around the implants, starting probably from 5 to 6. And then there's evidence of progressive bone loss around the implant, and especially if there's pus. So we will talk about the prevalence and the microbiome a little bit, and also about the pathology, because the pathology is different from normal teeth, and we should all understand the difference. So if you leave the microbiome, the lesions that form around implants are typically like acute type of lesions that are circumferential, like they are round, and they progress faster than periodontitis lesions. So they can progress in a year or two quite quickly. And if you have ever treated these, they feel different. So when you have a periodontal vertical defect and you clean that, there's a lot of work to be done. So when you open up a periimplantitis lesion, it's like a little jelly that comes off from the bone because there's no kind of a fibers going into the bone that keep the tissue there. So it's like a jelly type of tissue that you will be able to remove fairly quickly. Like it's kind of like an abscess, kind of a resembling tissue. What's important is that we don't have a good separation of the biofilm by the pocket epithelium, because there's no true pocket epithelium in periimplantitis. What that means is that the bacteria are in direct contact with the tissue and inflammatory cells. So that makes it much more acute situation around. So you have lots of PMN cells and macrophages that are trying to fight the bacteria, because in periodontitis, you have to remember that bacteria are out of the body. They are in the pocket. In periimplantitis, the bacteria are inside of the body because there's no separation by the junctional pocket epithelium. So those are the biggest differences in terms of pathology. We did with Dr. Kesavalu, we did a preliminary study on rats placing implants and then introducing red complex bacteria for 12 weeks, and then looking at the periimplantitis lesions, how they form. And this is one picture from our study. So implant was then removed, and you can see in the healthy implant, you can see the bone level here. Sorry, I should bring my mouse to the right screen. So here's the bone contact, connective tissue, and the peri-implant epithelium. Higher magnification of that will tell you that there's keratinized epithelium, and this will be the little bit that is attached to the implant abutment. And this is a bone implant contact in a healthy implant. So with periimplantitis, you can see that the epithelium has expanded, but it doesn't go down and separate the inflammation and the bacteria from the body. So it kind of stops short, and then we have a lot of inflammation going on. And now, instead of having the contact with the bone has been replaced by inflammatory cells, likely mostly polymorph leukocytes. So where there used to be bone, now there's an inflammation tissue. And why? Because there's a bacteria living on the implant threads now. So the biofilm is here, and that's why this bone has been replaced by the tissue that can then try to eliminate the bacterial contamination. Prevalence of periimplantitis. So there are a number of studies showing the prevalence at various levels, and it really depends where the threshold has been placed, meaning how much bone loss you have to have and how deep pockets to get the diagnosis of periimplantitis. So one of the better studies was from Dirks, because it was they went to the state level, and they randomly picked patients that they examined. So it's not looking their own patients or the university patients. They were all randomly called patients from the implant register. So if you put the bone level for peri-implantitis to the level of 2, then there's 14.5% at the patient level and 8% at the implant level. So if we, depending where the threshold level is, that will dictate how much peri-implantitis is. But in general, it has been kind of agreed that it's around 20% of the implant, which is every 5th implant that we get peri-implantitis. So in this study, they were looking for the risk factors, and periodontitis almost always comes up. In this study, there were some other factors, number of implants and who is placing them, and implant brands. And surprisingly, Straumann implants came as the best. But we have to remember at that time, Straumann implants were the only ones who were that were at tissue level, and they didn't have a bone level implant at the time. So that may skew the results. So I don't think the difference is actually that large. Very recently, there was a study on the Norwegian population, again similar, that they didn't go and look at the university population or in their own practice. They called patients from the register and did a study what the prevalence is in the Norwegian population. The results are quite similar. So if they have over 3 millimeters of bone loss and 6 millimeters of pocket depth, then they have 17% of peri-implantitis level, and then at the implant level it was about 9%, so close to 20%. So they're always around 20% at the patient level, and a little bit less on the like a half of that in the implant level. And of course, again, when you change the thresholds, the numbers will change. But overall, I think we have to say that about every 5th implant will have a problem, or every 5th patient will have a problem. And we already discussed that what classifications they are for, how advanced the disease is. And in the most advanced case, when the pocket tips are nearing 88 millimeters and more than 50% bone loss, those are the cases where we are considering whether the implant actually needs to be removed. And some cases, yes, and there could be some cases where no. While in the earlier cases, early and moderate, we can try to do something to save the implants. One thing that I did not mention too much about the kind of like a local factors is the emergence profile. So we try to create the emergence profile that is in the implant crowns that are similar to natural teeth, because that will make a difference. So there was a relatively recent study looking at the, where the emergence angle is and how does that affect the healing of the junctional epithelium and implant bone level. And what they were showing in this study, that the more angle you have, like when you got these 80-degree angles, your junctional epithelium is totally kind of destroyed, so you will not have good attachment at all, and the bone level is clearly reduced, and it starts reducing when you go to 60 degree angle, and less so when you are in the 20 to 40. So it makes a difference, and it overly makes a difference in terms of the biofilm accumulation, how the tissue will heal initially, and so on. So, if you have this kind of a construction on the crown on an implant, that you will create an area where the patient will not be able to clean. Okay, I lost my. So this is even more than in the previous study. So you probably don't have any good attachment here of the soft tissue. You will have biofilm forming underneath, and then clinically you will have periimplantitis. Residual cement, if you have cement restored or cement retained crowns, if you are not careful, there was a time when they were claiming all periimplantitis was caused by cement, but in fact, some of the studies show that there's no difference between cement and screw retain if you are not putting crazy amounts of cement on these structures. So the cement can be used. We tend to do more screw retain if we can, but some cases it's not possible. So the cement can be used, but you have to be careful not creating periimplantitis by pushing cement into the tissues, like in some of these examples. You can almost see like a calculus on the implant crown, but it's actually the extra cement that is coming out when the crown has been cemented. So you have to be careful with the cement. Let's talk about a little bit about peri-implant microbiome, how that differs from periodontitis and health. So implants create an environment where the microbiome is selected and adapted. So it's not the same as it is on teeth because it's a different environment. It's different from the soft tissue perspective. It's different from the material perspective that are used. And typically we also have deeper pockets and so forth around the implants. So there's a wide variation of species between that are shared by implants and teeth. But majority of individuals do not share the abundant species between the tooth and an implant, so they are different. So periodontal microbiome has higher diversity than implants, and there's a lot of inter-individual variations in between different implants. So the red complex bacteria have been shown to be present in periimplantitis lesions, and also the orange complex bacteria. I don't have to explain what those bacteria are, but those have been commonly found in studies where they are taking specimens from the peri-implant pocket and looking what bacteria are present in those sites. So conclusion is that peri-implant microbiome present microbiologically distinct ecosystem in health and disease. So one of my graduate students, I asked him to actually look at the biofilm that is retained on the failing implants when we take the implants out. So I asked him to take the implants out carefully without destroying the biofilm that is attached to them, and then trying to analyze, like Sokransky did in early days on teeth, analyze what is growing on the implant when they have been removed. This was published 2023. So you can see a couple examples of implants that we had decided that need to be removed because they had advanced periimplantitis. So then in this study, we look at the microbiome at the different levels of the implants, or not different levels of the implants, but different levels of the peri-implant pocket. So very coronal, like, at the sulcus level, and then deeper in the middle of the deep pocket, and at the bottom, closer to the bone. So we were trying to compare, is there a difference between the microbiome, how it looks morphologically on the top and the bottom of the pocket? So the answer was really that not that much. They look quite similar. What we found comparing to the Listgarten studies, so Listgarten was the guy who did it on the teeth 50 years ago, 60 years ago or more. So he found a lot of spirochetes, but we actually found only about, roughly 10% of the morphotypes were spirochetes. I mean, it may be an underestimate because they are not always easy to see because they are small. While the rods and filaments that can be kind of sometimes interchangeable, they dominated at all levels. So regardless, so most of the implants that we observed, they have the same kind of a biofilm all the way from the top to the bottom of the pocket. So basically from the sulcus to the bone level. I'm going to show you a few of the pictures because I think it's intriguing for periodontists to see some of the biofilm sitting on the implants in a scanning electron microscope. At least I have always loved these pictures. So you will see sometimes the rough surface. So here are 3 different images from the same implant. So you can see the biofilms at different levels of the failing implant. And this is a noble PioCare thionite surface that has these like little pits, and you can see how these filaments, they love to live in those little grooves, and you can just imagine how difficult it is to clean these implant surfaces, these rough surfaces, when they get exposed. And that's probably the biggest problem with trying to treat periimplantitis, to get rid of the biofilm altogether. And I will show you more pictures. So I asked Jay to color some of these biofilms on the teeth. And typically in many we see these long filaments, and they can be full of these filaments. In some other implants, it could be just rods and some extracellular material. So you can see them hiding in these pits. And you can put your, if you look at the dimensions, this is 5 micrometers. And one cross section of your beautiful titanium brush that you are trying to use to decontaminate implant is 200 micrometers, one bristle in your brush. So you can imagine how effective that will be to cleaning all these little bacteria from those holes. Here we see lots of cocci growing together, and then filaments. We see a long filament that has both cocci and rods attached to it, and lots of extracellular material. Some implants we see like a Campylobacter looking bacteria that has these kind of filaments coming out of the bacteria that are really, really long and connect to other bacteria, and sometimes almost look like it's a mono-infection because there's so much of them and the same kind. And surprisingly, every implant that we looked, they never really look exactly the same. So the impression comes that periimplantitis can be caused by a number of different morphotype biofilms. So here you have a beautiful corn cob, like you have a filament inside and lots of cocci around. Some of these implants are full of corn cobs, beautiful corn cobs everywhere on the top of the surface of the implant. Here you have largely mainly filaments and the same looking, almost looking like a mono-infection on the tooth. Of course, there's the thickness and layers on them. Here you have bristle brushes, the typical bristle brushes with few spirals or spirochetes. Those are probably spirals because they're longer. And then these bristle brushes where you have a long filament and rod type of bacteria attached to it. and they're all over the place on this implant, again, different. Then you have these beautiful combinations of long filaments, cocci and rods. So the world on the failing implant, it's beautiful, but it's full of these different kinds of morphotypes of bacteria. So you can't say that it's caused by one bacterium or the other. I think there's a biofilm that different kinds of biofilms can cause the disease. So treatment, we have a little bit time, so we will talk about the treatment of periodontitis. So almost all the studies that have shown that conservative treatment alone will be often unsuccessful, but it's still recommended for initial phase that these patients will go through initial therapy. But and milder cases maybe can be treated with localized antimicrobials, although they don't seem to be that effective. Systemic antibiotics is not recommended, and then most of these cases require surgical manipulation, and we will discuss what that could be. And sometimes implant surface modification, that will be the implantoplasty, meaning that the threads will be removed and implants will be made like the old implants that have a shiny surface on them. And the reason for that will be what I just show you, the biofilm, because that's the most effective way of eliminating the biofilm. You drill them off, basically. So in the 3-wall defects, you use bone graft alone most of the time. Like I will use polybios, the xenograft, slowly resorbing. We will talk about emdogain in a minute. And in some cases you can use membrane, in some cases you can go resective, and sometimes you do combination of those things. So there's no one way of treating periimplantitis, and there's no consensus exactly how to do it, except there's some consensus that combination treatment, like open flap with some sort of grafting material, may give a little bit better results. At least open flap gives better results than not doing a flap at all. And here you see the kind of a typical circumferential lesions around the implants, and then bone grafting that has been placed. Here's another case. You can see periimplantitis. A couple of the threads are exposed, and then you try to disinfect the lesion. If you can take the crown off and cover it, even better. Put the healing or the cover screw back and then cover it, and do bone grafting, and if you can, and then go back to the crown on a later day, or you just have to do it the crown in place. So open flap with some sort of bone grafting, and there's a little bit evidence, and this is the regimen I personally use. I'm not advertising anything. I don't have a conflict of interest, but I have used the enamel matrix proteins, meaning emdogain, in surgical treatment with periimplantitis in selective cases. There are no long-term, blind clinical studies. So this is probably one of the few case studies that you can find that seems to support that you may have some improvements if you use emdogain, but it's not truly proven. So I will show you a case here and 2.5 year follow-up where this periimplantitis, it's moderate, not quite advanced yet. So it's more than 1/3. So it's between 25 and 50. We decided to try to rescue the implant. And as you can see, what the rescue surgery was, I I'm drilling the threads off, so I'm doing implantoplasty. Then I'm applying the enamel matrix proteins on the top of the implant, and then I'm applying the combination of emdogain and bio-os into the defect itself. So this is a 2.5 year result. The probing depths are 3 to 4 millimeters, and there's no pus, there's no evidence or more bone loss around the site. So, so far it's a successful treatment, but we don't know what's going to happen long term. So sometimes if you have horizontal bone loss, you may have 50% bone loss, but you can just open the flap, remove the threads, and place the gingiva at the lower level and maintain both crowns. Like in this case, this was done one of the graduate students. So some of the studies show that the open flap is little bit more effective than not doing a flap at all for treating periimplantitis. And we have done some studies about what to do with the interior implant cavity, and so that, you know, if you treat them with antimicrobials such as chlorhexidine, there was a lot of talk about chlorhexidine, whether it should be used or not, and if it's in a sealed environment. So we use that to reduce the bacterial loads in the internal implant screw hole, basically, and so that it's quite effective lowering the bacterial numbers in the screw hole if you apply chlorhexidine at the time of the healing abutment placement into the screw hole. So trying to eliminate as much bacteria from the environment where the implants are. There's no longitudinal studies showing that this is effective for treatment of periimplantitis. It's just an example that the bacteria will be present in the implant screw hole if you don't do anything. We can skip that. So coming to the closer to the end. So this is how the rough surface of an implant. I show you already bacteria in these surfaces. So this is how it looks like and what the size of those pits and lacunae are. So we were then trying to do studies to how to disinfect the implant. So we did in vitro studies some years ago with my graduate students, and we were cultivating 3D multi-species biofilm on the top of the implant surfaces, and then we rinse them, and most of the biofilm goes away. But regardless of what the treatment was, there were lots of bacteria left in the lacunae of the SLA surface. So there wasn't really any difference between using chlorhexidine or phosphoric acid or tetracycline. The rinsing was equally effective in these studies. Or we even tried a new combination, and that didn't do anything either. We have done also a little bit studies of the biofilm removal with the airflow with glycine. So in vitro studies, we were shooting with certain distance from the implant using the airflow with glycine. And that we were able to show in these studies that when we first rinsed the biofilm and then applied the airflow, the consoles had a lot of bacteria still present. So if we didn't have any powder, it wasn't effective, but when the glycine powder was added to the airflow, that reduced the bacterial load significantly per field. So we also did without any rinsing, so just applying the airflow with glycine on the intact biofilm, and the same kind of results. And then you can do it at the 3 millimeter distance of 6 millimeter distance, and with 50% powder or 25% powder, it doesn't really matter. If you have the powder, it seems to be effective. So most of the glycine treated, airflow treated surfaces look pretty clean. So it's hard to see many bacteria there comparing to the control groups. And finally, then we were trying whether we can actually do it on an extracted implant. So we mark the implant with the little notch, and then we apply the airflow with glycine on the real implant that had been removed. So this area was blasted, and then the rest was control. And then when we were looking the blasted area, so it's only 5-second blast, and we have all these bits on the thionite surface, and this is the untreated area. So in our hands, the airflow seems to be fairly effective of removing biofilm if the powder is present, erythritol or glycine. So in our practice, the hygienist is doing this on maintaining the implants and also with the periimplantitis, periimplant mucositis patients. Not all the offices have this appliance, and I don't know what the situation is in India, how many are using the air or PerioFlow in the offices, but I mean, maybe you can comment on that when I finish my presentation, but it seems to be effective, much more effective than the chemical disinfection. So that's what was kind of our conclusion, that that traditional tools don't disinfect implants. So they when remove some from the pockets if the implant threads are exposed, and that's the situation that I'm talking about. So then the airflow will be better than most of the other ways of decontaminations, and compared to the chemical decontamination methods. And I still believe that the success of any the prevention is the most crucial, that we select the patients well, and then we prevent the periimplantitis from happening. But if it happens, so the biggest challenge of the treatment is the decontamination of the rough implant surface that has the bacterial biofilm living on it. So more studies will be needed, and I will conclude my presentation. Thank you so much.
Thank you, Professor LARJAVA. Now I invite Professor Farhan Durrani to chair to have his comments and summarize the Professor Farhan Durrani. Professor Farhan Durrani, are you there? Dr. Farhan, are you there? Not there. Okay. हाँ, please allow इनको allow कर देते हैं, इनको speak करते हैं. Yes, yes. Mute हो गया था.
Hello.
Yes, you're audible.
Professor HANNU, it was a very excellent lecture, and it was an eye-opener for us in India, especially the rat study which was done. So it was a good sharing of knowledge and a great eye-opener of studying of the biofilm. And as sir, you said that every 5th case is a problem of periimplantitis. Yes, this could be a problem. But one question which I wish to ask from you is, does occlusion play a role in periimplantitis?
It plays a role in the failure of the implant. So there are many documentations, and I have seen that that implant can actually get loose and be lost because of the occlusal forces. But that's not really peri-implantitis, although there's some inflammation going on from the occlusal forces. But it is like in a little bit like in periodontal disease that it probably can contribute, but until the implant gets mobile, I don't think, like we see failing implants that, you know, they kind of get like a periodontal ligament around them, kind of a bone loss around them, and then the implants actually get loose and patient can take it out without having the true bacterial driven. So the epithelium is probably still attached depending on the mobility of the implant. So it's not true peri-implantitis from the biological point of view, but occlusion. So that's why we always check occlusion on implants, because it's crucially important. But it may not alone cause any kind of issues, except you can have broken screws, you can have broken implants, you can have implants coming out of the bone because the occlusal forces are too harsh. So you can have all kinds of complications, but I don't think it plays a major role in the classic peri-implantitis, where we see these circumferential lesions forming around the teeth.
Thank you very much, Professor HANNU. One other question which I noticed in your lecture, you said that angulated implants is or can cause the periodontal ligament reattachment. Now, as Professor Malo advocates all-on-4, now most of the implants which they place is at an angle of almost 35 degrees and 45 degrees. So what is your take on that?
I mean, obviously we try to place the implants in a right kind of angle, but I know the all-on-4 technique that where the implants are placed in all kinds of angulations, and it can introduce a problem more from the biofilm control point of view than anything else. And there is another example, like the occlusal axial forces are not present on those angled implants. The forces are from the different direction. But many times on this all-on-4 create issue for the patient for the biofilm removal, and then that can cause problems, because we have seen patients on all-on-4 who have constructions that they cannot clean from underneath. So in my talk, I was more talking about the emergence profile coming from the implant head. And that emergence profile can still be acceptable even if the implant is in angulation. But I think the crucial thing is that we need to pay more attention is that whenever we are using these constructions, whether it's all-on-4 or more implants, especially when we are talking about the arch length implant reconstructions, that we make those constructions clenchable for the patients. Because in the past, we were seeing, especially in the maxilla, a lot of these constructions that were not, patient was not able to clean at all without taking the construction out. So here I think we tend to recommend more removable in those cases where a lot of ridge has been lost, because then you don't have to have a large overlap on the crest to compensate for the lost crest in the denture, so patients can actually clean around it. So everything needs to be made so that the patient will be able to do excellent oral hygiene around it, regardless of the angulation or anything else in implant dentistry. So we should go away from the constructions that prevent patients of taking care of themselves.
Thank you, Professor Anu. One thing which I wish to emphasize that here we don't get much of ENDO available in our country. So what cases when we have a peri-implantitis, we had been using chlorhexidine, saline, implantoplasty, then using bio-os, collagen. But as you said, this actually doesn't work. So that's very true, sir. And airflow could be the future where we can think of removing the microbes from the implant surfaces. And I hope this could be an eye-opener. And patient
So
selection, as you said, that is the most important thing, which I feel, as you said in the last slide of yours, which you mentioned that patient selection and treatment planning should be the best thing to avoid a future kind of a peri-implantitis. That's what I felt, sir. What is your say in that?
yeah, so is ENDO is not available in India? Is it more of a cultural or other reasons?
I don't know, sir, but the problem here is ENDO becomes very actually expensive for the patients to buy. And they are not selling it properly.
So even if you have the lower amounts, like now they have come, I mean, we only have like these 0.15 milliliter doses that the patients then pay much less. So even those are not available.
No, actually what happened, sir, that the company marketing, they have stopped marketing it very well because they don't see the market for their product.
Okay, but it's technically available, but it's not used.
Yeah, that's the problem. The company went right.
So I mean, I have done implant rescue surgeries with bio-os and some sort of decontamination. Initially, I tried phosphoric acid and hope that will work, but then we did some studies showing that it's not that effective actually. The problem with the airflow is that it's, at least in North America, is not recommended or approved for using during surgical setting because of the small risk of emphysema. So I know that some periodontists are using it anyways during the surgery for this infection. So what I have done, I haven't used it in our office, although we have the machine. It's in the hygiene office or operatory. So many times I remove the threads if we don't have aggressive implants with aggressive threads. I remove them by implantoplasty, and then I do the bio-os and hope for the best.
Yeah,
because
same thing.
But now, I mean, I have been routinely using ENDO in combination because, I mean, our fee, we kind of lump the ENDO and the bone graft fee together, so we will give a patient a little bit of a discount.
So, Professor LARJAVA, Professor Farhan, actually we are short of time.
Yes.
So I'm thank Professor LARJAVA and Professor Farhan for such a thought-provoking discussion. And we can have it.
Thank you very much. Thank you.
Thank
Thank
you.
you, Dr. Saif. Thank you very much.
Thank-
Thank you, Professor LARJAVA. Thank you very much. Thank you.
Thank you. So now we are going to move to next lecture. Dr. ARBAB ANJUM will be the moderator, and it will be on ortho-periosynergy. There are two orthodontics and periodontics specialty confluence for a better healing outcome. Over to Dr. ARBAB for introducing to start the session.
Thank you, Dr. Saif. Our next session is on ortho-periosynergy. the ortho-perio relationship is like a symbiotic relationship. Periodontal health is generally improved by the orthodontic tooth movement, whereas orthodontic tooth movement is often facilitated by periodontal therapy. So for the next session, the chairperson, we have Professor Rajan Gupta. Sir is professor and head at Himachal Institute of Dental Sciences, Ponta Sahib. And sir has an experience of more than 25 years. Welcome, sir. We have Professor Muhammad Tariq. Sir is a professor at Dr. Ziauddin Ahmed Dental College. And sir has an experience of more than 20 years. We welcome you, sir. For the speakers, we have two experts in the field of ortho-perio synergy. First, I would like to introduce Professor SANDHYA MAHESHWARI. Ma'am is a professor in orthodontics at Dr. Ziauddin Ahmed Dental College. She has an experience of more than 24 years, more than 115 publications, and an average H index of 16. And for the periodontology, our expert is Professor N.D. Gupta. Sir is a professor in periodontology with an experience of more than 27 years, H index of 19, and more than 125 publications. So we will have these presentations in continuity, and in the end, we will have a discussion. So over to you, ma'am.
Thank you, Dr. Arbab, for a nice introduction. Firstly, I'll thank organizing committee of this GIAN course to giving me this opportunity to talk about ortho-perio synergy. This topic is very close to my heart. Slides. As you know, in today's dentistry, for rendering the best comprehensive dental services to our patients, the paradigm has shifted to an interdisciplinary approach. It integrates the knowledge, skill, and experience of all the disciplines of dentistry to maximize the treatment results. When we are talking of interdisciplinary approach, we always talk about team. And orthodontists make the team of oral surgeons, periodontists, prosthodontists, restorative dentists, pediatric dentists. Here, team makes together everyone achieves more. Together everyone achieve more means we are going for the optimal results. Consultant as well as patients both are benefited by this approach. When we are talking of orthodontic treatment, we need some adjunctive procedures from other specialties to have a better outcome, like replacement of missing teeth, tooth buildup to compensate the Bolton discrepancy, especially like in paglateral cases, periodontal rehabilitation procedures needed before orthodontic treatment, surgical exposure of impacted tooth, or nowadays we are going for accelerated orthodontics where we need the help of periodontist. But some conditions require adjunctive orthodontic treatment to facilitate the other dental procedures. Like for example, orthodontic surgery. We do the pre-surgical orthodontics in a severe jaw discrepancy to facilitate the surgical procedure. Same thing in a pre-prosthetic procedures, we do the redistribution of space, open the space, or we do the vertical correction to have a best outcome for the patient. In endo, we do the extrusion of fractured tooth so that restoration can be done easily. Today, I'll be talking of orthodontics and periodontics, how orthodontic tooth movement can prevent and alleviate some periodontal problems. When we are talking of periodontally compromised teeth, we should understand this. Periodontitis is a inflammatory conditions mediated by different types of mediators like cytokines, prostaglandins, enzymes, and neutrophils. And orthodontic also need to identify this clinical form of inflammatory condition beforehand. As we know, orthodontic process is also an inflammatory process. And this combination of inflammation between the periodontitis and orthodontic forces is a deadly combination. It causes more rapid destruction of periodontal tissue if it is not well controlled. So, regardless of orthodontic skill, an excellent orthodontic correction can be compromised if we fail to acknowledge the periodontal problems priorly Hence, recognizing the patients who are susceptible to periodontal issue is vital for successful treatment. Orthodontic treatment, when used alongside periodontal therapy, can improve oral hygiene by creating a more easily cleanable dental area. Orthodontic treatment can have a positive effect on periodontal wound healing as these two processes are closely linked. Periodontitis often causes the unfavorable tooth movement, which can be addressed through a orthodontic repositioning. When we are talking of periodontics and orthodontics, we must understand what are the etiology behind the periodontal problems, which can be caused by the different types of malocclusion. Here I'll be talking of equilibrium theory. As we know, tongue and perioral muscles can affect the dental arch form and teeth position. Usually, teeth are positioned in a neutral zone with the balance of these forces. But if you see the diagram, you can see the tongue pressure is almost double to the lip pressure on the lower incisors, and upper incisor tongue pressure a little less with comparison to the lip pressure. So this unbalancing of forces is controlled by the pedial metabolic activity. This active stabilization of pedial is required to be positioned the teeth in a neutral zone. If it's not there, that can be because of inflammation or periodontal inflammation which can raise the periodontal fibers, result in alveolar bone loss, or some occlusal dysfunction, disruption of equilibrium because of the tongue thrust habit or because of the incompetent lip seal, affect the balance, and this causes the teeth to drift, tilt, or rotate. In general term, we say it's a pathologic migration. If you see there's a bone loss and this center of resistance is moving apically, and this is the cause we have to see because this causes the pathologic migration. Like in this case, you have a patient is already periodontally compromised. With that, if tongue thrust is also there, that it is more detrimental. So we have to check this beforehand before going for any periodontal management and orthodontic management. If some cases, if your eruption is like that, your teeth are having a crowding, there's a more plaque retention, calculus formation, gingival inflammation, and bone loss, then alignment, the proper positioning of these teeth helps in improving the periodontal condition. Because this is a self-cleanable area, so we can improve the condition by aligning the teeth. Sometimes some tooth are in a traumatic occlusion, and that causes the migration of that tooth. Like here, if you see there's an anterior crossbite, one tooth is out of arch, there's an excessive force on this tooth, causing the gingival recession and periodontal distraction. This tooth, if you see, is labially placed, and your lower lip is causing the trauma to the upper incisor. If you see here, is a H2 is by traumatic occlusion, again causing the destruction of periodontal tissue. Before going for any treatment, we must find out the etiology. Like if you have interferences creating the excessive force and trauma on certain teeth during biting and chewing, so by correcting the alignment, the teeth orthodontics can reduce the risk of periodontal tissue degeneration and help in preventing the periodontal problems to occur. Like in this case, you have a gingival recession because of the anterior crossbite problem. So what we have to do, we have to go for the alignment labeling, and you can see the healthy gingival margin with the regeneration of tissue without any surgical intervention. Now I'll talk about some points to consider when combining the periodontal treatment with orthodontic treatment. There are some points we should see. Timing of the treatment. Timing of orthodontic treatment is most important because of the interlinked process of bone resorption and apposition. Therefore, inflammation during OTM needs to be well controlled. Means OTM should be started once your periodontal therapy goals have been made. Like for this example, we have a generalized spacing in this case with the inflammation, but inflammation is not controlled before the orthodontic treatment. When we have closed the space, there's a squeezing of inflammatory tissue in between the teeth, and there's a more inflammation is there. And this more inflammation sometimes changes to fibrous one, and then we have to go for the surgical intervention to correct this type of problems. So we have to see, like in this case, against a generalized spacing case with gingival recession here, severe bone loss, if you see in the anterior region, but we have gone for the preliminary periodontal therapy. Then we have started with the ortho treatment. Then you can see the healthy teeth without any gingival enlargement in between, and regeneration of bone is there if you see in our anterior teeth. This regeneration of bone is obviously done with the periodontist. They have gone for the host modulation therapy along with the orthodontic treatment. Etiology, I have already talked about this. We should understand the etiology, which is causing the pathologic migration like trauma, tongue thrust. Any minor dental crowding can create a major periodontal concerns. Inter-arch relationships should be checked beforehand for traumatic occlusion for crossbite. If we see any type of thing, we should give a like habit breaking appliance can be given, or posterior white plate can be given to disocclude the teeth from the trauma before starting our orthodontic treatment. Now, if you are treating a periodontally compromised case, we have to change our biomechanics, as we are working on a same biological substrate, that is alveolar bone. And this lack of alveolar bone support is probably the most common and challenging dilemma confronting this interdisciplinary team. The reduction in periodontal support decreases the PDL surface area, which is essential for bearing the orthodontic forces. Center for resistance shifts apically with bone loss. As a result, the same force generates larger movement and more extrusive movements compared to the teeth with healthy periodontal conditions. Like if you see, there's a apical position of your center of resistance is there, and this causes the change in root to crown ratio. This change require adjustments such as applying the modified movements. Modified movements, we usually have to apply the higher MF ratio in these cases to have a controlled tooth movement, which necessitates the application of light, well-controlled forces for physiologic bone remodeling in a periodontally compromised cases. Positioning the brackets closer to the gingiva, we can modify the movements by adjusting the brackets position, wire bands, and applying design to achieve optimal tooth movement. If we are going for orthodontic treatment through a regenerated bone, we must understand that this regenerated bone may differ in the composition, density, vascularity, cellular activity, which can affect our speed and efficiency of OTM. So we should plan accordingly. We should avoid the movement to go ahead of the alveolar process anatomical limits. Like for example, if you have a retroclined incisors in class 3 cases and you want to compensate more, it can cause the labial positioning of the roots, which can cause the fenestration and dehiscence. So it can worsen the periodontal destruction. So we should avoid, we have to place the roots in a alveolar housing to have a proper healing process. Lastly, retention is very important to regenerate the alveolar bone, because we know there's a lag time is there and we are dealing with the adult cases. Naturally, with the age, this lag time will increase. Accordingly, we have to plan our retention in these cases. Now I'll talk about some cases. Like we have this case with the gingival recession. This gingival recession, if you are having, it can be during orthodontic treatment or before the orthodontic treatment. Our treatment sequencing should be like this. We should have a home care, oral hygiene, root planning, and subgingival debridement that be done. Antibiotic therapy, if necessary, should be used. Means preliminary periodontic therapy should be done before starting our orthodontic management. Then orthodontic management of these teeth is very important with the proper root positioning. Here means torque control is important. You are keeping the root in a alveolar housing only, not beyond that. Otherwise, gingival recession will not be corrected. If you see with the alignment leveling, your gingival recession is decreased here. If required, perio surgery can be done after the orthodontic treatment like gingival graft. If we are talking of guided tissue regeneration and orthodontics, as we know in the morning session, we have talked about lot of technique for a regenerative therapy of periodontal management. So here I am talking some orthodontic movement can be planned to enhance the graft integration and stability. Controlled light forces promote the bone apposition in defect areas, potentially improving the bone density. So this is not my case, but I want to show if you want to do the vertical orthodontic repositioning, it can improve the certain types of osseous defect in periodontal patients. This tooth is extruded with severe bone loss is here. If you go for alignment of this tooth, you can see there's a regeneration started in this area. So extrusion, intrusion of isolated tooth can show the positive effect on the periodontal health. Often the tooth movement eliminates the need of resective surgery sometimes. This case done in our department, we have this one is severely periodontally compromised with almost 3-degree mobility. If you see, we have gone for the alignment labeling, the rotation of teeth with the very planned way with the lighter forces, and especially we have used a TMA wires for this purpose. And if you see well-aligned arches, healthy periodontium around that tooth is there. If you see the X-ray of this, then you can see severe bone loss in this region and regeneration is going on. So this way, when you are going for alignment labeling, repositioning of teeth, you can go ahead with the remodeling of the bone and that will affect your bone healing positively. Other cases, usually we see like your tilting of molars. This tilting of molars is usually because of the loss of tooth. Their drifting of adjacent teeth is there in a space. And this causes the loss of proximal contact, gingival poor margins are there, and loss of interradicular bone and pseudo pocket formation. In these cases, we can open the space, upright the molars, or we can do the uprighting of roots only and close the space. Like for example, this case is there with the 3-6 decade and 4-6 is missing. Patient has come after 6 months with visually inclined your 4-7 and 3-7 with the complaint of sensitivity in these regions, food lodgement and degenerative effect is started. We have gone for the alignment of these teeth. So this aligning the medially inclined molars can help in decreasing the pocket depth and enhance the bone formation in that area. Because of the stretching of connective tissue on the medial side, that stimulates the remodeling in that area. Now I'll talk about some complex cases usually coming to our department from the other departments with multiple edentulous spaces, loss of vertical dimensions, collapse bite, alveolar bone loss, poor oral hygiene, loss of function, and aesthetics is always compromised in these cases. And these cases are always need a multidisciplinary approach. Like this case has come to our department at the age of 30 years with a significant fear of dentistry because he is running from one clinic to other clinic with a different treatment plans and lot of money involved. When we have seen this case, we found there's a multiple edentulous areas with the spacing, tongue thrust is there, receded gingival margins are there. And if you see collapse bite, your upper canine is touching the lower alveolar bone and lower canine is touching the upper alveolar bone. And in the lower arch, you can see the sorry, excuse me for my bad throat. And reduce alveolar bone support. In this case, what we have done, we first started with the periodontal therapy only. prophylaxis is done, control of inflammation. Then we have gone for the occlusal correction. In that, consideration for pre-prosthetic treatment is done, correction of vertical loss, supereruptive teeth, especially like counterpart. We have gone for the correction of occlusal plane and redistribution of edentulous spaces. We have gone for alignment labeling. You can see there's a vertical opening, canines are opened, and redistribution of spaces there. But problem is your one is severely resolved bone is there. We have to go for the endo-perio of these two incisors with the host modulation therapy only. So this is the like pre and final version of the case, and you can see the happy smile of the patient. If you see the X-ray, severe bone loss you can see with especially in the lower anterior region, and your canines are extruded. We have gone for alignment labeling. Endo-perio treatment is done in these two cases. Other than that, there is no root canal treatment required in this case. We have positioned the root such so that they can take a load of your fixed partial denture very well. This is another case which has come at the age of 19 years with missing anterior teeth. And because of this missing maxillary anterior teeth, there is an overclosure of your mandible, and this overclosure of mandible causes the resorption, your bone anterior ridge is resorbed severely. So if you see there's a deep bite which is causing the trauma to the upper alveolar ridge, it's a class 2 malocclusion with severely resorbed ridge. What we have done, we have gone for alignment labeling with the intermediate removable processes. This removable processes is given as a bite plate also for the opening the bite. If you see, there's a well-aligned teeth are there with opening the bite here. This much of bite is there so that processes can be given easily. But problem is this bony protuberance. So for this, we need a help of periodontist for ridge augmentation that is done to facilitate the prosthetic rehabilitation. Then from here, we have used this fixed partial denture. In this case, we can use the implants also, but this patient is going for fixed partial denture only. So here, we are going for treatment, ortho treatment in periodontally compromised cases, but all cases cannot be done. Like we cannot go orthodontic treatment in all cases. We should avoid in some cases, like when you have a presence of uncontrolled infections or inflammation, inability to maintain the stability of the teeth in their corrected position, especially when you are shifting the teeth against the opposing bite forces or into a traumatic occlusion. Insufficient space is available. Don't go for the tooth movement in those periodontally compromised cases. If there is no support is there, anchorage value is not there, then don't attempt to go for the tooth movement. Like in this case, if you see, 6 is missing, 7 is also compromised, severely periodontally compromised case is there, and this severely periodontally compromised. Patient wants a Vivex correction, that needs a 4-4 extractions. But we haven't gone for that, just we have gone for the alignment labeling, removal of trauma so that we can have a healthy periodontium. At least patient can stay with the teeth with healthy teeth will be there. So we can say that if the patient is not cooperating, there is lack of motivation, then we should avoid this orthodontic treatment. Like in this case, we are going pathologic migration is there. We are going for ortho treatment, but you can see there is a calculus deposition again is there. A patient is not maintaining the oral hygiene, our whole exercise will be futile. So we should avoid this. We should avoid the tooth movement in a patient with systemic diseases like this, diabetes. So lastly, I conclude the orthodontic treatment protects against the periodontal breakdown by aligning the teeth, which provides the more cleanable area, reduce the harmful occlusal interferences, and damaging the oral highways. Periodontally compromised patient can benefit from orthodontics with the careful folds application and adjunctive regenerative therapies. It is possible to restore the lost periodontal structures while achieving the optimal tooth alignment. requires low, well-controlled forces to prevent further damage, and it should be done in a non-inflammatory condition to ensure the safe movements. Lastly, I can say orthodontic treatment as a part of interdisciplinary approach, when properly managed, supports the periodontal health, preventing the disease progression and promoting the bone regeneration. Thank you very much for patient listening.
Good morning, all. I will be speaking on the adjunctive periodontics for rapid orthodontics tooth movement. This presentation highlights the importance of collaboration between the orthodontics and periodontists in improving both the aesthetic and the long-term patient oral health with optimum results. Rapid orthodontic is an advanced approach aimed at accelerating tooth movement, requiring various periodontal procedures used to facilitate the orthodontic tooth movement. Why rapid orthodontics is the need of hour? The integration of orthodontics and periodontics has advanced with non-invasive and surgical technique that enhance biological response to mechanical forces, enabling the faster treatment while reducing the periodontal risks. Now, as all of you know, that the orthodontic tooth movement involves the resorption on the compression side, whereas on tension side there's a apposition of the bone. But this mechanism is due to the activity of various bone cells like osteoclast, osteoblast, and cement osteocytes. And this the quantity and quality of the OTM, that is orthodontic tooth movement, can be enhanced by various surgical, non-surgical, and biological approaches. But today I will be speaking only on the surgical aspects to see to accelerate the orthodontic tooth movement. Surgical means produces a noxious stimuli which will result in the release of pro-inflammatory cytokine, which activate the osteoclast progenitor cells. Thereby, there is a substantial increase in alveolar bone demineralization, which is transient and irreversible condition. Thereby resulting in osteopenia, it is the temporary decrease in mineral bone density. The osteopenia enable the tooth movement. You see the cursors when we do the surgery, the pro-inflammatory cytokine increase are released. They activate the osteoclast progenitor cells. These osteoclasts now they are differentiated into osteoclasts, and the osteoclasts now they cause the resorption of the bone. Now, when there is a resorption, at the resorption site, the macrophages come and they remove the resorbed bone, thereby decreasing the mineral bone density. This promotes the rapid orthodontic tooth movement. Once the tooth comes into their new position, desired position, there is an influx of osteoblast, and thereby there is a mineralization of the bone, and this is how the movement are facilitated. Now I'm discussing the few surgical technique which facilitate the orthodontic tooth movement. Coming to the first technique, the technique is periodontal accelerated osteogenic orthodontics. Periodontal accelerated osteogenic orthodontics combines a selective corticotomy, bone grafting, and orthodontic forces. Based on the regional accelerated phenomena, which was earlier, I described this RAP in the earlier slide. This technique was refined by Wilcox, which improved both the orthodontic and periodontal outcomes. Now, the advantages of the periodontal accelerated osteogenics that it results in increased alveolar bone width, shorter treatment time, increased post-treatment stability, and there is a decreased amount of apical root resorption. Which cases should be selected? The periodontal accelerated osteogenic orthodontic can be used in most of the cases in which the traditional fixed orthodontic therapy is used. POG has been shown to be efficacious in the treatment of class 1 malocclusion with moderate to severe crowding, class 2 malocclusion requiring expansion or extraction, and mild class 3 malocclusion. The procedure has certain contraindication. It is contraindicated in patients with active periodontal disease, in inadequately performed endodontic treatment, in patients with a history of prolonged corticosteroids use, in patients on medication which interfere with bone metabolism, such as bisphosphonates or non-steroidal anti-inflammatory drugs. Case report. But before that, I'm discussing the various steps involved. That is, first is the flap designing. Flap design should meet the following objectives. It should provide access to the alveolar bone wherein the corticotomy are to be performed. It should provide a coverage of the particulate graft. It should maintain the height and volume of the interdental tissues. It should enhance the aesthetic appearance of the gingival form where is necessary. Then second step in the paw is the decortication. By using number 1 or number 2 bar, round bar, in either a high-speed handpiece or dental implant blade, decortication is made in the alveolar bone to initiate the RAP response, but not to create the movable bone segment. This will result in osteopenia and increased turnover of the alveolar spongiosa with area of demineralization, which enables the teeth to be moved more rapidly. Typically, a vertical groove is placed in the interradicular space midway between the root prominence. This, you see that why I left this 4 to 5 millimeter of gingiva, just to preserve the crestal bone. The vertical groove was made 2 to 3 millimeter below the crest, and it should extend 2 millimeter apical to the apex of the roots of the teeth. And these two vertical grooves, they are connected with the horizontal circular shaped corticotomies. Now the bone grafting. The volume of the graft material used to dictate is dictated by the direction and amount of tooth movement predicted, the pre-treatment thickness of the bone, and the need for level support by the alveolar bone. This is closure. Now the final is closure technique. The primary closure of the gingival flap without excessive tension and the graft containment are the therapeutic endpoint of suturing. That is, it means that you should have a primary closure. Now, this is a case which I am showing you. This is a pre-treatment operative view of the patient. This is after giving the incision and reflection of the full thickness flap. These are vertical and horizontal corticotomy are done, and this is a decortication on the radicular surface. And after the bone graft is placed, to maintain the thickness, preoperative thickness of the alveolar bone, this is immediately after the primary closure immediately after the surgery. This is very next day of the surgery. There's no beautiful healing, no sign of inflammation is there. This is after removal of the suture after 7 days. This is a pre-treatment photograph, and this is 2 months after surgical treatment. The teeth are properly aligned and they are intruded also. So second procedure is ridge expansion corticotomy assisted orthodontic, that is RICO. The tooth movement across the atrophic edentulous areas is challenging situation, especially in mandibular posterior and edentulous segment, because of the predominantly cortical bone and less trabeculi bone. These tooth movement are often associated with complications such as tipping of the teeth into the extraction space and the root resorption, along with the increased treatment time. Kessler in 1976 suggested a mesial movement of the mandibular molar without mandibular molar should not be attempted because their roots are wider than the adjacent edentulous ridge and can cause the loss of osseous support. Sommer et al. Introduced a technique for expansion of alveolar ridge for the placement of the dental implant in the narrow alveolar ridge. Taking these concepts, Sommer's concept, we have developed this technique. Under this technique, under the local anesthesia, crestal incision was given and the full thickness flap are raised both on the buccal side and the lingual side to expose the alveolus. A straight fissure bar is used for gaining access through the cortical bone. Once the pilot opening is made on the cortical bone of the crest, a osteotome is used for widening of the cortical plates. The protection forces can be applied with using the T-loop, using anchorage from the anterior segment 1 week after the surgery. This is the line diagram, and we have done a vertical cut in the crest after raising the mucoperiosteal flap, and this widening should be equal to that the mesiodistal, the buccolingual width of the tooth to be moved, and the depth should also be below the apical end of the apex of the tooth to be moved. This is a pre-treatment surgical photograph. There's a constriction of the ridge adjusted to the second molar on both sides, and there's a presence of root sum at 3.6 and 4.6. This is a 20-year-old female presented with class 2 div 1 malocclusion with root stem of 3.6 and 4.6. This is the orthopentagram radiograph showing the tilting of mesial tilting of the second molar, along with there's a root stem on the adjacent to 3.7 and now 4.5. This is, we have given the incision and raised the mucoperiosteal flap on both sides. This is after expansion of the edentulous ridge. Now the orthodontic procedure after the ridge expansion, the orthodontic force application was done after 1 week after surgery. The space closure was completed in 3 months on both sides. The rate of tooth movement was 1.6 millimeter per month. This is a procedure, the full thickness flap on buccal and lingual side. This is expanded buccal and lingual cortical base. Now the protection forces are applied using the T-loop, and this is the consolidation of the extraction spaces. This is a retraction done. This is a post-treatment photograph. This is the entire space is now the 3.7 and 4.7. They are moved into space for the first molars. And there's a excellent occlusion is there. This is the radiograph pre-treatment radiograph. There's, as you see, that there's a tilting of the 3/6 and 4/6. This is after the protection surgery and the orthodontic tooth movement. Now, the third procedure is canine retraction via periodontal ligament dissection. These are periodontal distractor devices. Periodontal ligament dissection device was given by Liu and Tang in 1998. This concept was based on the dissection osteogenesis in tooth movement. This is in this the first premolar was first extracted, and two vertical cut was undermining groove was given on one on the devial side and one on the lingual side, and these two vertical groove was connected with the oblique undermining groove. And another procedure was given by in 2002, and it is known as dento-alveolar dissection. The dento-alveolar dissection moves the canine as a part of bone block using the corticotomies, allowing the bone and the tooth movement through dissection osteogenesis. But the difference between the dissection osteogenesis and the dento-alveolar dissection and periodontal ligament dissection is that the tooth in periodontal ligament dissection, the tooth is retracted by using the stretching of the periodontal ligament, whereas in dento-alveolar dissection, the tooth is, along with the bone, is moved as a one unit. Now I'm coming to the rapid canine retraction via periodontal ligament dissection. The approach is the mechanism of this based on the dissection osteogenesis. The extraction of the first molar is done first, then the surgical procedure is performed on the interseptal bone distal to the canine. This which will reduce the resistance. Application of dissection for the rapid canine retraction was done. The periodontal ligament dissection produces the osteogenesis. On the pressure side, canine interseptal bone complex move distally into inside the socket, whereas tensions on tension side, periodontal ligament dissection promotes the bone formation. New bone is generated in the gap of osteotomy at the approximate rate of 1 millimeter per day. Rapid canine retraction is achieved. The advantages of periodontal ligament dissection is that a significant reduction in treatment time by 6 to 9 months is there. There's an elimination of intra or extra oral anchorage during the procedure, which ensures a nearly complete anchorage preservation, added to the fact that it does not damage the periodontium, nor does it affect the pulp vitality. Disadvantage is that there is a need of specific surgical procedure and a supervised activation protocol. Difficulty in fabricating the dissection. Now, the indication of periodontal dissection osteogenesis, the severe crowding with higher anchorage need, class 2 div 1 malocclusion by alveolar protrusion, root shortening and malformation, as well as patient presenting with periodontal problems. Case report of this a 16-year-old post-pivotal female with the angle class 1 malocclusion with bimaxillary protrusion presented to our college for orthodontic treatment. Treatment plan for this patient was fixed orthodontic mechanotherapy with extraction of all 4 premolar and the retraction of the anterior teeth. This is a pre-treatment photograph of the patient. This is a pre-treatment orthopentogram. This is the dissection device which was prepared by custom made, and it's prepared by the Department of Orthodontics. The individual canine dissector was a tooth-bone semi-rigid device. The device consisted of an anterior section, a posterior section, a screw, and hex wrench. To advance a screw, a 360-degree activation of the screw produced a 0.5 millimeter of distal movement. This is the dissector, but end of this attached to the canine to be moved distally, and other end of the dissector was attached to the first molar. And this is the screw which has to be activated. Now this is a tooth canine, and this first premolar is first removed, extracted. Extraction should be atraumatic. Then in the extraction site, we give two vertical undermining groups, one at the buccal aspect and other at the distal lingual aspect. And these two vertical undermining groups were connected by the oblique undermining group. This is to reduce the resistance for the canine to be detected. This is the first premolar was extracted, and then we did the osteotomy at the two ends, and this in the same way which I discussed in the earlier slide. Now the distraction protocol. The distractor is activated immediately, can be activated immediately after the surgery or after 5 days of the latency period. The distraction time is 8 days, for 8 days, and the maturation time is 28 days. After this 28 days of the maturation time, the distractor is removed and the retainer is kept. Now the activation protocol, the distractor activation can be initiated immediately after the surgery or after the latency period of up to 5 days. Activation are always performed at the rate of 0.75 millimeter per day, 3 turns on the screw at once, or divided into 3 activation of 0.25 millimeter during the day for the patient comfort. This is a distractor in place. This is a canine, and this is a first molar. Now the result after distraction. This is after 8 days of the activation. The canine is moved distally into the first molar site. This is the complete photograph. We have placed the band on the first molar. The surgery is performed. The distractor is placed after activation of the distractor. The canine is moved into the first premolar, and after the maturation period of 28 days, distractor is removed and the retainer is released. This is the, see the things. This is a pre-treatment photograph and the post-treatment photograph. Now the conclusion about the, since the long orthodontic patients have been asking for the shorter treatment time, and today we do have the method that can accelerate the orthodontic tooth movement safely. They come with additional advantages such as reduced rate of relapse, reduced orthodontic pain, and reduced root resorption. And these things can be achieved with a proper interdisciplinary approach. Thank you very much.
Thank you, Professor N.D. Gupta sir and Professor SANDHYA MAHESHWARI ma'am for an elaborative review on ortho-perio interrelationship, which you showcased with well-treated cases and excellent follow-up records. Now, I would like to invite the chairpersons for their observation and remarks. Professor Rajan, please, and Professor Tariq.
Unmute.
Professor Rajan, please, sir, for your expert comment.
Unmute.
Okay.
Am I audible?
Yes, sir. Yes, sir.
Okay. I think it was an excellent presentation by Dr. SANDHYA and Gupta. And especially the cases shown by Dr. SANDHYA in advanced orthodontic treatment and advanced periodontal cases were really good. I think those cases we thought were meant for implants, but the way she managed those cases orthodontically is really wonderful. And I just want to ask one question only. There are many diastema cases which are referred to us from the orthodontic department, and they say the frenectomy needs to be done. But there are certain literature is available in which they say there is no need to do frenectomy because orthodontic pressure in itself will remodel the fibers. I just wanted to ask if frenectomy should be done before orthodontic treatment or after orthodontic treatment.
सर आप तो अनम्यूट हैं सर मेरे स्पीकर
Just a second, sir.
Yeah, sure.
Hello, sir.
Yeah,
Yes,
hello.
ma'am, we can hear you.
Good morning, madam.
Actually, sir, in a midline diastema, my experience is we should close the space first, then we should go for the frenectomy.
Okay.
Otherwise, there is always a scar tissue which
Yeah.
creates a problem in closing the space. So
Okay.
according to first close the space and then go for the frenectomy, that will be better.
Okay. And madam, the second question that has always puzzled me is in molar uprightening,
Yes, sir.
we have to place the brackets on whole of the lower arch, or we can place brackets on say 7 and 4 and 5 and then give an orthodontic spring and this will uprighten the molar.
Sir, again, it depends how much tooth movement is required. If
Okay.
anchorage value is needed more, then we have to go for the whole arch bonding. But
Okay.
if there is no requirement of anchorage, then we can have a 4, 5, and 7 bonding and give a spring for uprightening.
Thank you. Thank you so much, ma'am. It was very enlightening hearing you. Thank you, sir. Thank you, ma'am.
Dr. Rajan.
Thank
Thank
you.
you, Dr. Rajan.
Thank you.
Professor Tariq, please.
अनम्यूट करो Am I audible?
Yes, sir. Yes, sir.
I must congratulate Professor Sandhya Maheshwari and Professor N.D. Gupta sir for their wonderful talk on the first Professor Sandhya Maheshwari. She covered the importance of interdisciplinary approach very nicely. And she also covered nicely about the guided tissue regeneration, and she told us about the importance of the etiology in the management of the orthodontic treatment. And she also covered host modulation therapy. I must say that, madam, you have covered a lot of things in within no time. I was gasping to make pace with you. इसके लिए एक हिंदी में मुझे याद आ रही है कहावत कि गागर में सागर भर दिया मैम आपने. And for Professor N.D. Gupta sir, regarding adjunctive, he covered about rapid orthodontic tooth movement, and he covered PAO and RICO very nicely, and very nice cases he showed us. And he also covered PDL distraction and showed a canine distraction case. My only one question is for N.D. Gupta sir. For ridge expansion, which instrument is used for in RICO for ridge expansion? First, you have to make the cut in the alveolar crest to gain the access through the cortical plates. Once you reach the trabeculae, you can use a osteotome, or there's a ridge expansion equipment is also there, which are used in the implant cases. Okay, sir. Thank you so much, sir, for your wonderful talk once again. Thank you so much, sir. Okay. Okay.
Any
Thank you.
questions from the audience? So now we'll be moving on to the next session.
So next session will be about perio. Will be on periodontal lesions, strategies for better outcomes. So I now ask Dr. Rashmi to ask the chairperson to join, and I ask the first speaker. There will be two speakers here, one periodontist and one endodontist. And I ask Professor Vivek Sharma as a periodontist to start his talk.
Hello. Hello. Hope I'm audible to all. Now, maintaining our momentum, good morning to all attendees and distinguished guests. We hope to captivate you with another compelling presentation on perio-endo lesions, strategies for improved outcomes. Our presenters for this topic are Dr. Vivek Kumar Sharma, a professor in the Department of Periodontia and Community Dentistry at Ziauddin Ahmed Dental College. His focus areas include periodontal regeneration and the interplay between systemic and periodontal diseases. He has authored over 52 publications and received 182 citations and has made significant contributions to the field. Our second speaker is Dr. SHARIQ, an assistant professor in the Department of Conservative Dentistry and Endodontics. With over 37 publications and 357 citations, his clinical expertise and profound knowledge have consistently made a notable impact in the field. We extend a warm welcome to both of you, sir. Our session chairperson is Professor Pradeep Shukla. Dr. Pradeep Shukla is associated with the Department of Periodontology and Implantology at DJ College of Dental Sciences and Research, Modi Nagar, India. He has been honored by numerous awards and grants for his valuable contributions and discoveries in his prime research areas. His research interests encompass dental operating microscope, maxillary, molar, and mesiobuccal canal. We welcome you, sir. Last but certainly not least, we have our highly respected and esteemed principal, Professor R.K. Tiwari, as another chairperson for this session. With over 29 years of teaching experience, he has guided various conferences and programs with exceptional leadership skills. We welcome you as well, sir. Okay. Over to you, sir.
Good morning to all. Good morning to Professor R.K. Tiwari, sir, and good morning to Professor Pradeep Shukla, sir, and to all the participants. Very good morning, and thanks to Dr. Saif to have this wonderful course, especially on the oral wound healing, which is a requirement of nowadays with advancement of dental treatment modalities. So, myself, Professor Vivek, and my colleague, Dr. SHARIQ, we all be here to discuss the strategies for better outcomes of endo, perio, or the perio-endo lesions, whatever we want to coin the word. So start with some clinical scenarios. This patient visit our PG department with a scooting pain, and we, when examined clinically, having a deep periodontal pocket of 10 mm in the furcation area, and side by side, we can appreciate the deep caries lesion in the lower second molar. So, and the second case, that two come to our department with the mobility of the teeth, and one case was endodontically treated, but other was not endodontically treated when patient come with a mobile teeth. This is another scenario where the patient came only with a swelling and pus discharge. There was no history of pain, and when we examined the patient, that patient was having a deep periodontal pocket of about 15 millimeter. And when we go for radiograph, it was seen that there is some periapical lesion in relation to mesial root of the first molar, and it was having a history of the restoration. And this is a very interesting case where the patient come with a diffuse pain. No is severe pain, no severe problem of any other things, but only diffuse pain were there. That's why when we examine the patient and found to have a multiple period pockets, we go for OPG and found this scenario. These all things need some treatment strategy, and we should not forget that treatment strategies is not just not a clinical procedures. It's all about integrating the knowledge that we have, but we have to use our knowledge according to the patient need, and of course continuously refine our approach to achieve a better possible outcomes. Coming to the parental and endodontic relations, just imagine a tree with the deep roots inside a soil. These roots not only give an encourage to the tree but also absorb the nutrients from the soil. So any problem, any jeopardy in the integrity of a root or the quality of soil will ultimately lead to the destruction of the whole tree. So similarly, whenever we think of treating the perioendal lesions, they all require a holistic approach which can address both the endodontic component as well as the periodontic component to maintain the beauty of the teeth. So to understand the nature and course of perioendal lesions, I'd like to invite my colleague, Dr. SHARIQ. He will nurture you further. Dr. SHARIQ, please.
Thank you, Professor Vivek, sir. You've introduced the topic, and I'll continue from there. At the outset, I would like to thank the organizing committee, especially SEV, sir, for organizing such a wonderful symposium. Also, all the presenters, especially Professor HANNU, for taking the time, and the patients to present such a wonderful series of lectures, and all the participants and delegates who have presented as well for making this symposium a success. Also, I would like to congratulate the participants for having the patience to come and learn and take that initiative of improving and learning. We're all in the process of learning, and I hope to learn from all of the participants here and all the speakers here as well. My topic for today is perioendal lesions. My focus would be on the aspect of the endodontic aspect of the perioendal lesions. Professor Vivek Sharma, sir, would be carrying on the perspective of the periodontal aspect of the treatment. So the overview of my presentation is, I would first define what do you understand by endoperio lesions. We would talk about the etiology and the communicating pathways for the endoperio lesions. We would classify and categorize these endoperio lesions. And finally, we will be talking about the treatment, especially the endodontic considerations of treating endoperio lesions. And we'll be presenting a few cases as well at the end. So the learning objectives of this presentation is to understand the intercommunication between the pulpal and periodontal tissues. We'll then try to understand the classification, differential diagnosis, and prognosis of endoperio lesions. And I'll try to familiarize with certain clinical presentations of endoperio lesions. So if you look at the definition of endoperio lesions, the American Academy of Periodontology and European Federation of Periodontology in its workshop have defined endoperio lesions as a pathological communication between the pulp and the periodontal tissues, which may occur in acute or chronic forms. The American Association of Endodontics have given a more simpler definition. They've categorized it as a process involving interaction of diseases of the pulp and periodontium. So at the overall, if you look in this endoperio lesions, both the pulpal as well as periodontal tissues are affected concomitantly. The etiology we'll next deal with the etiology and the intercommunicating pathways between the pulpal tissues and the periodontal tissues. If you look at both these tissues, they are closely interlinked with each other, and the communication pathways might be anatomic or it might be non-physiologic pathways. The anatomic or the physiologic pathways might be communications through apical foramen between the pulp and the periodontal tissues. The dentinal tubules might also be pathways of communication, and also lateral and accessory canals. There may be non-physiologic pathways of communication between the pulpal and periodontal tissues, which might occur through perforations, fractures, and developmental grooves. If you look at this diagram, this shows that the various intercommunications between the pulpal and the periodontal tissues. So the tissues are closely interlinked, and one disease process from one tissue might communicate with the other tissue, and this is what causes the endoperio lesions. But we should remember that none of these lesions can occur without the etiology of infection. So bacterial contamination should be present, and the communication makes the traversement of the infection between the tissues and causes the infection of the endoperio lesions. Here again, it illustrates how the infection can communicate from one source to the other. You might have a primary endo lesions which might communicate with the periodontal tissues to create a secondary periodontal involvement, and vice versa. So these communications interlink, and the disease is interlinked with each other closely. So after we've understood the basics of how the communication takes place, we'll delve into the classification of endoperio lesions. There have been many systems of classification, but primarily we'll be focusing on two classification systems. One is the Simon's classification, which is broadly accepted by the American Association of Endodontics as the system which this body follows, and they've categorized endoperio lesions into 6 categories, modifying Simon's classification. The Simon's classification was originally a 5 classification system, which was extended by the American Association of Endodontics into a 6 system of classifying endoperio lesions. These are primary pulpal lesions with extension to periradicular tissues. Then again, primary pulpal lesions with extension to the periradicular tissues with secondary imposition of periodontal diseases. Then you might have primary periodontal lesions and primary periodontal lesions with extension to the pulpal tissues. And you might have combined pulpal periodontal lesions, which are true combined lesions. And the 6th category was added later on by the American Association of Endodontics as concomitant pulpal periodontal lesions, in which the disease process exists independently in both tissues and are not interrelated with each other. So both in the 6th category, there is presence of pulpal lesion as well as periodontal lesion, but they are occurring independent and they're not interacting with each other. So this is the categorization of Simon's. So in primary endodontic lesions, the source of infection is the pulpal tissue, which might traverse through the periodontal tissues to create endoperio lesions. Again, in primary endo secondary perio lesions, what happens is the persistence of infection of endodontic source leads to contamination of and progression of pulpal infection of periodontal infections as well. So the primary source of infection was the pulpal infection, but secondary contamination by periodontal tissues has led to a secondary periodontal involvement. Then you might have primary periodontal lesions, where the progression of the lesion happens from the periodontal tissue, and it might which, if it involves the pulpal tissue, leads to secondary primary periodontal lesions with secondary pulpal involvement. And finally, you might have a combined or a concomitant lesions, in which in a combined lesions, the pulpal and the periodontal tissues merge together in a single conformed lesions, and it is impossible to distinguish which component is being contributed by the pulpal infection and which component is being contributed by the periodontal infections. Start moving. Slide. Another system of classification, which is followed by American Association of Periodontology, is looks at the drawbacks of the Simon's classification, where it is difficult to classify lesions because you have to look at the historical perspective of how the disease progression has taken place. In the American Association of Periodontology, and European Federation of Periodontology have perio lesions with root damage or without root damage, because this is important in assessing the prognosis of the tooth. And also, once that assessment is done, then we further assess that whether it is associated, that endoperio lesion is associated in a periodontitis patient or a non-periodontitis patient, and the periodontal pockets are further graded into grade 1, grade 2, grade 3. It's important to understand that while making a differential diagnosis of whether the source of infection is pulpal or periodontal, we need to look at the pulp sense. There are important parameters. Most important of them is pulp sensitivity test. I'm sorry, there's a mistake here. In the pulp sensitivity test, it should be in the pulpal involvement, it should be negative, while in periodontal involvement, if the source of infection is periodontal, the pulp sensitivity test would be positive here. Also, if you look at the characteristics of the pocket, in pulpal involvement, the pocket is generally single and narrow, while in periodontal source of infection, the pocketing might be multiple. Multiple pockets might be present in the patient, and the pockets are wider coronally. Also, if you look at the pattern of bone loss, it is localized in cases of pulpal infections, and it widens apically, while in periodontal infections, the pattern of bone loss is wider coronally. So this is just an assessment of the pocket depth presentation in pulpal infections, which is, if you look at the pocketing depth, it is the pocketing is normal, and it deepens in certain in a narrow region. In treatment considerations, what you have to look is if the source of infection is primary endodontic lesions, you suspect that it's a primary endodontic lesions, you have to treat it endodontically and keep it in evaluation for 2 to 3 months. If the lesion completely heals, then you do not have to intervene any further. The periodontal component is only assessed after 2 to 3 months period of assessment after endodontic treatment. However, in cases of combined lesions and primary periodontal lesions, these would be dealt with by Professor Vivek Sharma in detail. So this is again an assessment based on the European Federation of Periodontology and American Association of Periodontology system, in which you assess whether root damage has taken place. If the root damage is there, then the prognosis might be compromised, and you'll have to make your treatment decisions accordingly. These are certain cases. In this case, if you look at this case, there was a deep pocketing, narrow pocketing depth. And if you look at the characteristic of the lesion, it is wider apically, narrows down towards the alveolar crestal region. So it is, and you can also visualize caries on the proximal region, which is extremely deep and involving the pulp, because the vitality tests were negative. We made an assessment that this was a primary endo lesion. We treated it endodontically, and the lesion healed. Again, in this case, there was a lesion with a focal involvement and just with a narrow pocketing depth, and just an endodontic treatment led to the healing of the furcation defect as well. Again, palatogingival grooves can cause endoperio lesions, and in this case, because the grooves was extending apically, we sealed. We did an intentional reimplantation along with the endodontic treatment, and we could assess complete healing. So these are some of the cases of palatogingival groove. Here, in this case, there was presence of palatogingival groove, but the tooth was vital, so we did not intervene endodontically. Just a periodontal intervention resolved the lesion. Again, this is a case where there was both evagination and invagination. The evagination had led to a periodontal aspect of the pocketing, and the invagination had led to endolesion. So we treated it endodontically, but we also did a radisection of the lingual accessory root extension, and we could appreciate the healing after a follow-up period. This was a case of a picomarginal defect. This wasn't resolving. The initial endodontic treatment wasn't resolving the lesion. So we made an assessment to do an exploratory surgery. We saw that there was a picomarginal defect, and we, along with the endodontic surgery, we did guided tissue regeneration in this case to get the healing. So finally, the key message in this presentation is that the endodontic infection has been regarded as a local modifying risk factor for periodontitis progression. There's a general agreement that with proper endodontic treatment, periodontal disease of pulpal origin should heal. In case of primary endodontic disease with secondary periodontal involvement, they should be treated endodontically first, reviewed after 3 months, and only then the periodontal therapy should be considered. In cases of primary periodontal disease with secondary endodontic involvement, it requires both endodontic and periodontal treatment interventions, and this aspect of the periodontal disease intervention would be dealt by Professor Vivek Sharma. These are my references. Thank you. I would like to call upon Professor Vivek to carry forward this lecture. Thank you so much.
So thank you, Dr. SHARIQ, to give a very good understanding of the nature and course of periodontal lesions, and especially giving the classification and the treatment protocols of endodontic therapy in endoperio lesions. So after Dr. SHARIQ's session, we come to know that periodontal lesions are those perplexing intersections where the periodontal and endodontic pathologies converge, and of course, they present a unique challenge in dental practice, because if either the root trunk has been decayed or the root has been decayed, loss is of tooth, and we have to save the both is our priority. When we talk about the strategies for the treatment of the endoperio lesions, they are just like navigating the complexity of endoperio lesions is akin to solving a multifaceted puzzle where each piece influences the other. Since these lesions represent a confluence of periodontal and endodontic pathologies, and the successful management hinges on comprehensive strategic approach. If we fail to place one piece at the right position, whole puzzle get unsolved. Because I have to deal with the periodontal therapy. So I must talk about the rationale. The rationale of periodontal treatment in periodontal lesions is rooted in a comprehensive approach to eradicate the infection, promote the healing, and restore the function of our tooth supporting structures. Whenever we deal, lot of confusion arises what to do first. As Dr. SHARIQ has said, when primary endodontic lesion is there, then we have to start with the endodontic therapy. And when the origin is primary periodontal, we should start with periodontal, and later on we go for endodontic therapy. When we talk about strategies, our strategies must concentrate on healing of endo and perio components so that we can restore the function. The word healing is very important in aspect of periodontal component, because in endodontics, the healing means the removal of the all infectants from the root canal. But a perio aspect is a wider. So we must know about the intricate dance of healing. When we start a periodontal therapy, it starts from reduction of microbial load and inflammation to achieve a new granulation tissue formation where we have a good fibroblast, good and osteoblast migrate to the sites, which can lay down a new connective tissue and blood vessels. Of course, we likely to have a collagen and extracellular matrix components to be synthesized, providing a scaffold for a regeneration. So after this granulation tissue formation, we should concentrate on the periodontal healing promotion, which are characterized by the regeneration and reattachment of periodontal structure, and of course, enhancing the prognosis and to survival. We should concentrate on the patient comfort also, because ultimately the quality of, if we can achieve the quality of life to the person, then only our treatment is successful. In essence, we need a strategy. Why? And this strategy must be a thoughtful integration of clinical expertise, patient engagement, and adaptive planning. My dear colleagues, don't forget this word, patient engagement, because without patient engagement, we cannot achieve our goal. Strategy is just about orchestrating all available resources and knowledge to create a personalized roadmap that leads to successful healing. Coming to the strategies, I have precised all strategies in this flowchart. First of all, we should know the origin of lesion. As Dr. SHARIQ has elaborated, the importance of the origin, whether it is primary endodontic or primary periodontal nature. Then start with a sequential treatment plan. Of course, the first endodontic therapy is very important, but before endodontic therapy, we have to provide a conducive environment for the healing. Whether we go for sequence treatment plan, three factors are very important. One is the factors that affect the healing. Because now, after the endodontic therapy, we are going for healing of the periodontium. A lot of factors are there which affect the healing of periodontium. So we should not neglect those factors. Second is the patient education and behavioral modification. Because now, since the periodontal therapies are a long-term therapies, they need a patient compliance, and that require a behavioral modification of patient also. And of course, the third important thing that affect our sequential treatment plan is the knowledge of new technologies and incorporating all these new technologies in our treatment. So after this, considering all these three things, we make a customized treatment plan according to the patient need. And if required, we have to go further on for a further comprehensive periodontal therapy with some adjunctive therapies also. And the last but not least, and I say very important, is a maintenance and follow-up protocols. Without this maintenance and follow-up protocols, we cannot succeed in our endoperiolesion therapy. Coming to the first point is a precise and thorough diagnosis to understand the lesion origin. As Dr. SHARIQ has elaborated in his slides, lesions are only of three types: primary endodontic, secondary, primary periodontic origin, and a combined. But I say one more thing is there. Because endoperio lesions are coined when there is a communication between the periodontic component and endodontic component. The endodontic component has been involved after the periodontic involvement, or the periodontal component has been involved after the endodontic involvement. But a transition phase exists where the periodontal component is just likely to enter the endodontic component. If we can stop there, we can prevent the occurrence of true endoperiolesions lesions. So we must not forget the importance of precise diagnosis and the initial diagnosis. To diagnose at a proper time, it is always better to treat one component rather than to wait and treat both components. As this case is there, which I have presented in the first clinical scenario, this case, you can see here that the bone loss, the loss of periodontal structure is to the apex of the tooth. Similarly here also, but patient is not complaining any pain, and whenever we go for the this vitality, the vitality test was positive. So here we should be concentrate whether the lesion is not on whether this lesion has traversed to another component or not. Second is, of course, as Dr. SHARIQ has said, the we must go for endodontic treatment first. But before endodontic treatment, the non-surgical periodontal therapy is utmost important because it will remove the local microbial load and, of course, lead to the reduction in the inflammation. So start with a normal scaling and opening and then go for the endodontic treatment. As Dr. SHARIQ has said, that assessment period should be there to start a periodontal therapy. And when we see that the periodontal therapy, the periodontal condition is not getting resolved after the 4 to 6 weeks of endodontic therapy, then we should have some surgical interventions. Because this sequential treatment planning aims to minimize the cross-contamination and, of course, allows for a cleaner assessment of each therapy effectiveness. Whenever we are in between the sequential treatment planning and customized treatment planning, there are certain factors which we must consider because these affect the periodontal healing. Now we are dealing with the periodontal part. What are those factors which affect the periodontal healing? Utmost is the extent of lesion. Of course, the severity of lesion matters, whether the pockets are shallow or the deep, because they may impede the complete regeneration. And the localization is as important as the severity, whether the single site is there or the multiple site is there. Always, we must consider the severity and localization of the periodontic lesions. The treatment protocol is very important part, but side by side, the most important and usually we neglect is a patient's systemic health. My dear colleagues, the systemic health is a very big impact on periodontal health also. Periodontic component may not link to the systemic health, but the healing of periodontic component is very much related to the patient's systemic health. We should consider whether the patient is having any systemic disease like diabetes, or patient is having some habits of smoking or tobacco. And very important thing, the immune status of the patient is very important, whether the patient is immunocompromised, because immunocompromised patient always have a delayed healing response. This thing, we should not hesitate to consult a physician to first rule out the systemic disease and treat all these systemic problems. And the final thing, oral hygiene practice is very important because without patient compliance and the professional maintenance of oral hygiene, we cannot achieve a desired resolution of periodontal component. So for that we have to, sorry for this technical hitch-up. The fourth is the patient education and behavioral modification. Of course, you have to be involved with the patient so that patient will be more compliance regarding the treatment and treatment protocols and procedures. And the thing which is we lack, we generally avoid, we don't want to get in this thing is a nutritional advice of the periodontal component. Since it now, if we go for a comprehensive therapy, need a good nutrition status for the patient. So always examine the nutrition standing of the patient. And side by side, we must have our we should always do a evidence. We should not feel shame to do an evidence-based practice. Something is written in the book, something is written in the journal, new research is coming on, but always also we must rely on evidence-based practice, because in evidence-based practice, some unsolved or puzzled questions get answered. After the sequential treatment plan, we must customize our treatment plan, because every case is a different case. Every case is a unique case. No two endodontic treatment can be the same. No two teeth of the same patient will have a same response. So also always we should customize our treatment plan and having a personal care in our mind. Of always we should assess the individual risk. Always be sensitive regarding the culture, beliefs, and preferences, because these things, the culture, belief, and this very important, these culture, belief, and preferences may affect the treatment acceptance and the compliance. And then the tailor the intervention which will suit best for the patient need. Whenever we talk about the comprehensive periodontal therapy, addressing the periodontal defect, we should go for simple periodontal flap surgeries, which means the reflection of flap and degranulation. But we can also go for certain regenerative procedures where different membranes and different materials as a bone graft, maybe allograft, xenograft, or autografts can be used. And of course, we should also concentrate on the localized drug delivery. Localized drug delivery always has a beneficial effect where the systemic condition is compromised. These LDDs are very beneficial for resolution of periodontal defect, especially in the case of endoperioral lesions. Because the rationale of this comprehensive periodontal therapy is that the tailored periodontal interventions always decrease the microbial load, reduce the inflammation, and restore the supporting structure to improve the prognosis. But we must have a scope of integration of agentic therapies which always enhance the healing and regeneration, right? Likely use of PRF, use of EMDs, laser therapies, and photodynamic therapies. These agentic therapies can significantly enhance the treatment outcomes by promoting a faster and more effective healings. The most important part whenever we go for making a strategy for treatment plan is a rigorous maintenance and follow-up protocols. Starting from the first day of SRB till the end of the endodontic treatment, the patient compliance is not a big factor. Why? Because patient might having a pain, and the pain will go only when we go endodontic therapy. After the endodontic therapy, generally all the pain goes off. But we know, or if our patient is educated properly, he have an idea in his mind that my therapy is still incomplete. So that's why the follow-up protocols and maintenance is very important, so that there will be complete resolution of endoperioral lesions. For that, we need a regular recall visits, and we must monitor the healing pattern. And of course, if there is a recurrence, we should have a prompt management of the recurrence. This ongoing care tracks issue early and sustain the periodontal health over the time. So coming to the case discussion, because ultimately we have to make some strategies for the clinical cases. I will concentrate only on the periodontal components. This is a very good case. Resident of our department, Dr. Rashmi, encountered this case. This is a preoperative photograph where you can see a very poor oral hygiene of a patient. And this patient comes with a diffuse pain in all over his mouth. A complaint about diffuse pain. Seeing this periodontal condition, a thing comes in our mind that patient might having only periodontal pain, but we don't know. When we go for a probing, we go for charting, they were generalized deep pocket. And we decide to go for a OPG. This OPG that you have might seen in previous slides also. OPG reveals a generalized bone defect in the posterior area, and this bone defects thus leading the apical portion of the root on the both sides, on the left and on the right side of the first molar and the left side of this premolar. Patient, no, remember one thing. The thing is, patient complain of diffuse pain. No severe pain, no swelling, no complaint of suppuration, nothing else. Just a diffuse pain. We go for I have said, the initial diagnosis is very important. We go for a vitality of the vitality test, and all vitality test all teeth was positive. So it comes to know the main condition, main problem is of periodontal origin. The endodontic component is not involved. Since patient was not having a severe pain, we always we concentrate ourselves only to the healing of the periodontal. We put this case in that category where there might not be involvement of endodontic component. We don't jump in hurry that this is a combined endoperio lesions. It appears like that it might be an endoperio lesion with this radiograph, but the vitality test was positive and there was no severe pain. We limit ourselves to the treatment of periodontal component. We go for a phase 1 therapy of scaling group painting. We wait for some time and feel there was no recurrence, means pain. Pain has been subsided with SRP, but since we are a periodontist, we go for the surgery. This is the case of this right side. We go for a flat reflection. We etch the tooth with tetracycline application. After placement of DFDVA, we do a suturing. And on the left side, we do the same flap surgery again. And with the help of the hydroxyapatite and PRF membrane and etching of tetracycline, we complete this periodontal therapy. Now imagine, no, you should not consider that we have not touched the endodontic component. We do only the periodontic component because we put this case on that transitional phase where if the periodontal aspect is left untreated, the endodontic component may get involved. And surprisingly, this is a radiograph after 3 months. This right side radiograph is after 6 months of the therapy where Dr. Rashmi, under the guidance of Dr. Saif, has placed DFDBA. And this is the on the left, this is the where you place the hydroxyapatite. No, sorry. On the left, we have placed hydroxyapatite, and on the right, they have placed the DFDBA. So this is a very wonderful case where we can prevent the communication of infection from periodontal component to the endodontic component. So we prevent the starting of the endoperio lesions. We just limit this lesion to the periodontal component and we save this tooth. So 3-month follow-up is good, quite good. In fact, we have also have this X-ray of the right side of 6-month follow-up. Coming to the second case, this case, as in the clinical scenario previously I have explained, in both cases, in this case, a patient come with a mobile tooth. When we go for an X-ray, we see this thing, and we take help of endodontic people, and they guide us, and we go endodontic therapy, and ultimately, after endodontic therapy, we found a very good results. And you can see after the 3 months, a patient was placed with this metal crown, and his tooth is still intact even after the 3 months. This case, Dr. SADIQA has done in our department, and patient come with a severe pain. When she examined this patient in OPD, and she found to have a pocket of 10 millimeter, and that there was a callus lesion on this distal aspect of 7, 6 on distal aspect of 6, and we found that this tooth was having a negative vitality test, and this is the pure endoperio lesion. We reflect and found to have a very good furcation defect. She treated with this defect with the regenerative materials and found achieve a very good results. And this patient is still in our observation. 2 months has been passed, and we were trying to get a crown later on. Coming to this case number 4, where we are not able to save the whole tooth, but yes, we can save the tooth in half so that we can have this bridge later on with the help of also people. This patient also come with a mobile teeth and a painful pain in his right component of the lower arch. When we go for a X-ray, we found that the patient has been already treated endodontically. Now see, this patient came after the endodontic therapy to us, and we found that there is extensive bone loss in the distal aspect of this thing. We do a SRP, but mobility was not resolving. Then we decided, since there is a good periodontium here, we decided where this tooth should be go for hemisection. We do a surgical process, and after hemisection, this is just after hemisection, and this radiograph is 3 months post hemisection, and you can appreciate the gain in the periodontal supporting tissues. So after all these case scenarios and after treatments, we should come to the conclusion. The successful management of periodontal lesions means one thing is clinical healing. There must be absence of all symptoms like pain, swelling, sinus tract, all these things. Functional without any discomfort. The importance is tooth should be functional. Mere having a tooth in the oral cavity is not our aim. Our aim is that tooth must be functional. And of course, the radiographic healing must be present, and a good periodontal health and already success is the first thing to management the endovascular lesions. And patient compliance. Patient should feel satisfied, and patient will feel satisfied only when his or her tooth is in the functional state. And last and very important is that there must be long-term stability. And for this long-term stabilities, we should always consider the points which we have discussed in our strategies regarding the factors that affect the healing, regarding the patient compliance, customized treatment plan, maintenance protocols, and patient compliance. With this, I end up our presentations. Thank you very much for patience learning. One thing that we when this
and I just put a picture of Hawk. Why so?
Hawk is having a very good vision. He always analyze and act. So whenever doing a periodontal cases, first thing is that we must analyze, observe, and act sharply. Thank you very much.
Thank you so much, sir, for such an informative session. Now I would request our chairperson, first of all, our very respected and honored principal, sir, Professor R.K. Tiwari, sir, to please give us the concluding remarks, followed by Pradeep Shukla, sir.
सर को अनम्यूट कर दीजिए
Hello. Hello. Can you hear me?
Yes, sir. Yes, sir.
Initially, host was not allowing me to speak, and so that it was delayed. Very nice presentation by SHARIQ and Dr. Vivek Sharma. Very nice presentation. The one thing just I want to know, if there is a combined lesion of advanced origin, so who will intervene first? Endodontist or periodontist?
So in my view, in advanced lesion, the endodontic treatment must be first, but the initial SR scaling and repairing should be first thing, then the endodontic therapy. Because without endodontic we cannot treat the endoperial lesions.
No, I am talking of combined lesion. Combined lesions. What Shariq? What is your opinion?
As Professor Vivek sir had said that the endodontic intervention should be done initially because you need to make an assessment of how much of the component of the disease process is of pulpal origin, because the severity of the periodontal infection would determine the prognosis of the tooth. So once you've done the endodontic treatment, you get the healing of the pulpal source of infection, then you can make an assessment of how much of the problem is being caused by the periodontal problem, which actually determines the prognosis of the tooth. So endodontic intervention should be done first, and then the periodontal assessment should be made accordingly of whether the tooth is salvageable and how much of the periodontal defect is the cause of the problem. So you need to make an assessment. Assessment would be only after the endodontic intervention.
So according to you, first we will finish the endodontic treatment.
Yes, sir. Yes.
Or we should go simultaneous.
So as sir said, as Vivek sir said that the initial scaling and root planing you can do, but if you need to make an assessment of how much of the intervention, whether you need to go in for a guided tissue regeneration, which sir would elaborate further, you need to make an assessment of how much of the combined lesion is because of the endodontic source. So after the endodontic healing has taken place, you can make an assessment of the periodontal prognosis. So endodontic intervention should be initiated and then a periodontal assessment. And sir would elaborate further on what the periodontal, the treatment protocol.
So after having this endodontic treatment, we prevent that any toxins that might be present in the pulpal origin now rule out. So endodontic therapy is the first, and after endodontic therapy, we should assess. We should wait for 2 to 3 weeks at least. Then go for periodontal therapy. Because without endodontal
Very nice
therapy,
presentation. Good answer. Very nice presentation. I'll not take much of time. Both the presentation, ortho, perio, ortho, endo, were very nice, and they definitely get our college to be integrated in these branches so that we can perform better. So from my side, it's very nice presentation. Thank you very much.
Thanks.
I would request Pradeep Shukla sir.
Good afternoon, all. Good afternoon, all. First of all, I extend my heartiest gratitude and thanks to the GIAN organizing committee for giving me this opportunity to be the part of this excellent extravaganza of periodontology. And the today's lecture, if I talk about the endoperio lesion, it was nicely taken up by Dr. Vivek and Dr. SHARIQ. And it certainly they have started from the beginning, because diagnosis is definitely important, because diagnosing and in the endoperio lesion is more important. And because I know that so many of the budding periodontists, they are the part of this symposium, so they'll get definitely a message that how to treat with. But I just wanted to add something, Dr. Tiwari sir. My regards to Dr. Tiwari, and that his question that which part should be taken up first, are the endo or the perio in cases. I think the alleviation of pain is more important as far as the patient's perspective is there. So we should, whatever is the region, maybe the endoperio or the perio-endo lesion, first of all we should comment with the endodontic, and we have to alleviate the pain, and later on we proceed accordingly as per our whatever the protocol suggests us for the procedure. Thank you very much.
Thank you, sir. So thanks. Thank you all. So let's do end of this today's sessions. We'll be meeting tomorrow, 8:30 a.m. and we will be having a case discussion with Professor HANNU LARJAVA
and another case-based learning in small groups, which we have already communicated to 7 colleges are participating in it. And their representative will be answering to Professor HANNU's questions. And I've already shared that case series of Bill Williams. So that will be very fun to do tomorrow. And then we'll having strategies for wound healing by Professor HANNU LARJAVA. Then we'll have an MCQ test. 15 MCQs will be shared, and every participants are required as per GIAN's guidelines are required to do that test. And a feedback form. Every participant is required to fill a feedback form. So after that, we'll have a small validatory function to honor Professor HANNU by our university dignitaries. So that's the end of today's session. You may leave the chat Zoom meeting. Thank you. Live.